Good morning. Good morning. I guess this practically has to be in my mouth. I'm Marty Cohen, the Vice Chair of the Commission. On behalf of our Chair, Stuart Altman, and my fellow commissioners, let me welcome you to the Health Policy Commission's 2019 Cost Trends hearing. This marks the 7th hearing since the establishment of the Commission with the passage of Chapter 224 in the Acts of 2012. Just as 2012 was an inflection point in our efforts to address healthcare reform in the Commonwealth, I think we are once again at a key inflection point. As you will hear from our speakers this morning, while we have succeeded in keeping cost growth within the benchmark established by the Commission, the trend paints a picture of residents taking on a higher burden of premiums and cost sharing through copays and deductibles, often at rates that are higher than wage and inflation growth. And as important as the cost burden is to residents and employers, costs alone are not our only concern. With a variety of mergers, consolidation, new payment methodologies, and transparency tools, all designed to strengthen and streamline our healthcare system, healthcare has become more, not less complex, and more difficult for even the well-informed consumer to navigate. I am sure everyone in this room could share a story about their own or a loved one's experience in accessing and receiving care. We can do better, and we must do better. The next 2 days present a unique opportunity for us to hear from our state leaders, Governor Baker, Speaker DeLeo, President Spilka, and Attorney General Healy, as well as to learn from leaders and advocates in healthcare here in Massachusetts. This marks my 5th Cost Trends hearing, and I'm always amazed at the breadth and depth of our presenters and the frankness of the testimony given by our witness panels. I expect no less over the next 2 days. As the Boston Globe so eloquently put it last week, the Health Policy Commission's job is to, quote, get under the hood, to see what's behind the numbers and to recommend specific actions to move the Commonwealth forward. Although it appears my colleagues and I aren't dressed in our best mechanic suits, I believe we are ready to get our hands dirty. So let's pop the hood and get started. And to do that, I'm going to ask Commissioner Tim Foley to come to introduce our first speaker. Commissioner Foley.
Thank you. Good morning, everyone. How are we doing today?
Good.
All right. That's great. Well, I have the distinct pleasure to introduce our first speaker to kick off this annual Cost Trends hearings, to welcome our speaker, DeLeo, to the podium here today. As folks in this room know, does not need much of an introduction. We've all worked very closely with him on healthcare policy and legislative issues related to that. He's been a leader on these issues for a very long time. He's had played a tremendous role and had a huge impact on every piece of healthcare legislation that's really kicked this off, and starting with Chapter 58. And so we welcome you here today, Mr. Speaker. We look forward to your thoughts and comments as we, as Vice Chair Cohen mentioned, kick off our conversation around taking a hard look at where we're at, what are some of the trends that we're seeing, and what we can do as a commission to help inform policymakers around ideas and solutions to really lower the cost of care, increase quality and access, and ensure that consumers can pay their fair share to get what they deserve as well, and do that under a certain amount of money. So we welcome you, Mr. Speaker, for this important conversation, and thanks for being here with us today.
Okay here, or?
You can sit wherever you want, Mr. Speaker.
Close to the center. I'm sure I've got it right here. Tim, thank you so much for that kind introduction. Commissioners, David, it's always good to see you. And thank you for having me here this morning. I would also like to thank the Health Policy Commission for hosting us today. This venue, I believe, allows all the stakeholders from across the Commonwealth to reflect on our successes and to see where we can improve when it comes to providing affordable health care for our residents. I look forward to this hearing every year, as the testimony that is provided here really gives us the opportunity in the legislature to get a direction and shapes our decisions surrounding our healthcare policy as we move into the final half of our legislative session. Generally, when I make these remarks, my tone is cautiously optimistic because we have consistently met our cost growth benchmark, which serves as a barometer for our healthcare system. And this year is no different. We successfully met the new 3.1% benchmark. That is no small feat in today's environment. And while we should acknowledge our successes, we need to be honest with ourselves in terms of where we may be failing. Chapter 224 has changed the way that we look at healthcare and has helped us address runaway healthcare costs at a system-wide level. We have much to be proud of there. However, once again, we are faced with the cold, hard facts that patients are bearing the increasingly heavy financial burden of healthcare, with premiums and out-of-pocket costs rising at a quickening pace. And so we must confront what is working here and what is not. With 7 years since Chapter 224's passage, now is the time to examine our work and take the next step. Chair Benson, who I'm joined with here today, as well as Leader Mariano, Chair Michaelwitz, and the rest of the House are committed to taking that next step this session. As you all know, Governor Baker released his health care legislation on Friday, and yesterday I had the pleasure with meeting with the Secretary and hearing a little bit about the background or overall what was in the legislation. House committee chairs and staff are hard at work reviewing this legislation and weighing the different proposals. At first glance, we are glad to see that Governor revisited many of the concepts, I think, that we had in the Peter Cocott bill that the House passed last year. We will continue our review of the legislation, and we are looking forward to working with the Governor as well as the Senate in terms of how to best curb health care costs. While efforts to address out-of-network and surprise billing pharmaceutical costs are maintaining high value, low-cost care options in the community go a long way. There is clearly something here that does not fully explain why the cost for patients has continued to rise, despite our best efforts. We are here today and tomorrow to gather as a community to get at the bottom of this, and I'm looking forward to the discussion among experts and industry leaders. What makes the cost trends hearing so valuable is that every voice is here. We all come to the table. That is why it is an imperative that every stakeholder is present. If you are in this field, then it behooves you to be a part of this important summit and share your perspective. We are lucky here in Massachusetts that we have a collaborative atmosphere that allows us to engage in the hard conversations. We might not always agree, but we all are doing our best to support our residents and ensure that they are receiving the highest quality of care. It should not be understated how significant that is. I'm grateful to all of you in this room for enabling that important dialogue. One key ingredient to that dialogue is good data. We are exceedingly lucky to have Ray Campbell and the entire team at CHIA for doing the vital work of analyzing our healthcare data. In particular, I want to thank them for going that extra mile and to ensure that all of the data in this year's report show a full picture of how healthcare dollars are being spent. Good information shouldn't be underestimated, especially when it comes to crafting good policy. In the legislature, we rely on that data to make sure that we are creating informed, evidence-based policy. Setting the foundation for effectively policy involves gathering comprehensive data and making sure you have the full picture before you take up a proposal. Data for the sake of data, however, is not enough. That's why it's important to ensure that the data has a purpose. We do not want to increase the burden on stakeholders to deliver good data unless we plan to make use of it going forward. Striking the right balance is something that we continue to strive for. Another issue where good data is becoming vital is around vaping. Data collection and reporting on vaping-related illnesses has brought to the fore a national conversation about vaping products, and tobacco use more generally. And while the issue feels particularly acute now, advocates have been talking about youth smoking for several years now. I'm proud that we have taken action to address youth vaping last session by raising the smoking age to 21 and increasing these products in our public use ban. I know you'd like that, Ms. Madam Secretary. However, as we know, that is an evolving issue. And the House is working on the legislation to address this matter. Curbing tobacco use amongst children is a public health effort that has long-term benefits down the road, which can sometimes get lost in the more immediate health concerns. But if we are serious about improving our health care system, then we must think about the future impact of our policies and plan for the long haul. We need to be focused on the now, what's happening today, but challenges in the healthcare are never solved in 1 year, or even 7, as we've come to learn. While I don't want to downplay the value of immediate action, we should be placing a greater emphasis on long-term planning, even if that includes preparation for the unknown. Sometimes, long-term policies are about correcting missteps. Other times, they help us create a glide path to something better. This certainly applies to prevention efforts like curbing youth vaping, but also to the dynamic interplay between patients, providers, and payers. Why wait for a situation to decline before taking action when we know the right way forward? On the flip side, rushing to action when we know the landscape will change dramatically may be misguided. The House has always tried to be practical, thoughtful in policymaking, and we are making a cautious effort to do so with our eyes to the future. As I said last year, children are our future, and I am so pleased that we have been able to make some progress in improving the health care system for children in the last year. House legislation that we passed in July aims to break down silos of service to better address the complex health and wellness needs specific to the Commonwealth's 1.4 million children, and creates a foundation for better access and services and more data to inform future policy. When I spoke at the Chamber of Commerce earlier this year, I said that this would be a session-long focus for the House, and I stand by that. We are continuing to look at ways to improve how we support and care for the children of the Commonwealth. In particular, I'm looking forward to working with Chair Decker also on how we can address the behavioral needs of this population. as the importance of supportive and robust behavioral health services become more important than ever, more apparent, I should say, than ever, we need to consider how children can best access these services. This means finding ways to integrate mental health supports in services in our schools and in our communities, and not limiting to healthcare settings alone, so that children and families can access them from a variety of avenues. We know that we need to find ways to support families, particularly parents and caregivers. They navigate a complicated web of services, as well as the workforce who care for our youngest residents and are feeling defeated and, quite frankly, burned out. We also need to tackle the stigma associated with behavioral health diagnosis at a young age and encourage a more open dialogue. Caring for one's mental health is as vital as one's physical health. It is time that we stop valuing one over the other. If we're serious about long-term solutions, we need to make progress here. Caring for the behavioral health needs of our children from as early as infancy can have a dramatic impact on their later lives. To cultivate a healthier Commonwealth, we need to start now. In closing, I'd like to thank you for having me here today. It was an honor to kick off this year's discussion on how we should all communicate and collaborate to ensure that every resident of this great Commonwealth is able to access high quality and affordable health care. We in the House look forward to continuing being part of that conversation as we keep working towards creating a better system for all. Thank you all very, very much.
Thank you, Mr. Speaker.
Thank you.
It's now my pleasure to introduce the Executive Director of the Health Policy Commission, David Seltz.
Good morning, everyone. I'm David Seltz, the Executive Director of the Massachusetts Health Policy Commission. First of all, thank you, Mr. Speaker, for being here this morning and for kicking off our 7th annual Healthcare Cost Trends hearings. Every year you make it a priority to be here, and I think that's just a true reflection of your commitment and leadership to improving healthcare in the Commonwealth. So thank you, and we look forward to collaborating with you and your team on the next step in healthcare. Thank you. We have prepared an incredible agenda of expert speakers, leaders, and witnesses, all assembled here to wrestle with some of the most timely and pressing topics impacting healthcare delivery and financing in Massachusetts. We are so pleased to welcome all of you here. I'd also like to welcome the hundreds more that are joining by our online live streaming. In past years, we've had members of the public join the live stream from countries across the world, from the Philippines to Germany. So for you, good night or good morning, whatever is most appropriate. But thank you for joining us. I'd like to particularly recognize our partners from the legislature and our sister agencies who are here with us today. I'd like to give an especially warm welcome to the chairs of the Joint Committee on Healthcare Financing, Representative Jen Benson and Senator Cindy Friedman. From the minute you two were appointed to these important roles earlier this year, you dove headfirst into the deep waters of state health policy, which are sometimes opaque and often shark-infested. But you've taken on this challenge with your characteristic compassion, courage, brilliance, and humor, and with a clear-eyed vision of what you're trying to accomplish, improving healthcare for your constituents and for all the residents of the Commonwealth. The HPC stands ready to work with you to help achieve this vision, and we hope that these hearings are helpful for your work moving forward. And as always, to the staff of all of the elected officials who are here today, thank you. We know that you do most of the work. From our sister agencies, I'd like to recognize staff from Mass Health, the Group Insurance Commission, the Division of Insurance, the Department of Public Health, and the Connector Authority, who are all here. Thank you for your continued partnership. Very briefly, I'd also like to recognize senior health policy leadership from the Oregon Health Authority, who flew across the country to attend these hearings in person. Inspired by the Massachusetts model, Oregon is now working towards implementing their own all-payer healthcare cost growth benchmark. Additionally, we have Deputy Majority Leader Matt Lesser from Connecticut, who is here as well to learn about the Massachusetts experience. Thank you for being here, and we always look forward to collaborating and learning from the experience of other states. We're especially pleased to have you all here today because this year's hearings is being held at, and I swear, Mr. Vice Chair, I didn't crib from your notes, a crucial inflection point for the future of healthcare reform in Massachusetts. Since the passage of landmark healthcare legislation, access legislation in 2006, and healthcare cost containment legislation in 2012, Massachusetts has been a national leader in healthcare policy. We've made significant progress in improving insurance coverage for our residents and restraining our once skyrocketing growth in healthcare spending. However, as has been stated already multiple times this morning, despite this progress, there is still a high burden of healthcare costs and employers on residents, leading to significant affordability challenges. 1 in 4 Massachusetts residents has an unmet healthcare need due to cost. Stronger tools and policy changes are needed to ensure that Massachusetts continues to be a national leader in health policy. As deliberations on the Beth Pass move forward, the HPC will continue to collaborate with the Baker-Polito administration, the state legislature, the healthcare industry, and many other stakeholders here today by providing our objective research and data-driven policy recommendations. This annual event is representative in so many ways of our highest ideals for public discourse. And it is reflective of our history of state policy leadership in healthcare that aims to improve healthcare for everyone under a banner of shared responsibility and accountability as a true Commonwealth of Massachusetts. Over the next 2 days, we look forward to engaging with you on all of the progress we've made so far and to identify together further practical and actionable solutions necessary to meet this vision for the next 7 years. Before we get going, a few logistics. As I mentioned earlier, the hearings are being live streamed from our website. Following the hearing, the video will be posted on our YouTube site for posterity. And for those of you that are watching online, the full presentations are also posted there so you can follow along. If you haven't already, please pick up a program book from HPC staff at the welcome desk. It's good for 2 days, so we encourage you to hold on to it and bring it back tomorrow as well. We also sincerely welcome public testimony from any member of the public. If you would like to provide public testimony, please register ahead at the welcome table with HPC staff, and public testimony will begin today at around 2:30. The Wi-Fi information here at Suffolk is located on the back of your program book, and we encourage you to tweet at us during the hearing using the hashtag CTH19. If you have any questions or comments, please do not hesitate to reach out to any HPC staff. Finally, there's one important person that I want to recognize earlier that I didn't get a chance to acknowledge, and that's the esteemed chair of our Health Policy Commission, Dr. Stuart Altman, who is unable to attend this year due to a health issue. I had the great opportunity to see Dr. Altman this weekend and chat with him, and he wishes very much that he could be here with us today. He advised me to share 2 crucial insights. 1, it's all about the money, and 2, it's the prices, stupid. Stuart, if you happen to be watching on the live stream, You too can feel free to tweet at us at CTH19. We wish you were here too, and we're looking forward to having you back soon. Thank you, Vice Chair Cohen, for so ably and amiably stepping in this year. Moving forward in our agenda, it is now my pleasure to introduce my friend and partner, Ray Campbell, the Executive Director of the Center for Health Information and Analysis. Every year, CHIA releases a seminal report on the performance of the Massachusetts healthcare system. So in order to provide a fact-based foundation for this hearing, I'd like to turn it over to Ray for part one of our annual progress report. Thanks, Ray.
Thank you very much, David. Good morning, everyone. My name is Ray Campbell. I'm the Executive Director of the Center for Health Information and Analysis, affectionately known as CHIA. And I'm here with Ashley. Why don't you introduce yourself for folks?
Hi, I'm Ashley Storms. I manage one of the teams that contributes to this report.
A modest description of Ashley's significant contributions to what I'm about to review, hopefully accurately. Perhaps her facial expressions will give you an indication of when you need to ask me follow-up questions for clarification. No, just kidding. All right, great. We have a clicker. Okay. So just a quick overview. We're going to talk first and foremost that CHIA's annual report is heavily about the financial dimensions of the Massachusetts healthcare system, and so we will talk about total healthcare expenditures. We will also talk about trends in Medicare and Mass Health, and then move on to private commercial insurance trends. So we'll look at those three major components of the healthcare financing system: Medicare, Mass Health, and private commercial insurance. And first, I want to just mention, the role of CHIA's annual report, and I think it's already been captured by the introductory remarks, is to provide the factual foundation for the extensive health policy discussions that ensue in this state. They were initially focused, I think, very specifically on cost control. It's broadened and become somewhat more nuanced as we're dealing with affordability issues, which aren't quite the same as cost issues. But the role of CHIA's annual report is to provide the factual foundation for these discussions that are to come. When I refer to the annual report, I should mention it's a combination of things. It's a very extensive chart book, which some folks are lucky enough to get a hard copy, but mostly it's a downloadable PDF. There you go, Secretary Sutter certainly rates. But the PDF is available online, and with that is also available a very significant data set in the form of an Excel spreadsheet with a number of tabs that has a lot of all the data that's used in the report and much additional data besides. And we also have technical documentation on how we do the work. So I encourage folks to look at the actual online materials. In terms of acknowledgments, we really have to thank CHIA's data submitters. This is, and it was mentioned by the speaker, CHIA is funded by assessments on the healthcare delivery system, but what we do is all runs off of data that we collect from the healthcare delivery system. And so it imposes real costs on our data submitters, and we try to be respectful of their time and their money, and we want to acknowledge their efforts because without that, this report wouldn't be possible. And then lastly, CHIA's staff really puts in a very significant effort to pull this report together. This year in particular, because we have a number of other major activities going on at the same time, so want to thank the CHIA staff and the actuaries that we work with to pull all this together. Okay, so turning to total healthcare expenditures, the top line number, Massachusetts spent $60.9 billion in 2018 on healthcare. That's $8,827 per person, which on a per capita basis grew 3.1% from 2017. And 3.1%, as it so happens, is the benchmark number set by the Health Policy Commission. It had been 3.6. 2018 was the first year that had been lowered to 3.1. Okay. This chart shows the state's performance vis-a-vis the benchmark and the annual change in total healthcare expenditures over the last 6 cycles that we've been doing this exercise. And you can see the shape of this curve is actually mirrored by national trends. So if you looked at national healthcare expenditure trends, it would be a very similar shaped curve but higher. So we've been lower than the Fed, than the national numbers, but there was a significant uptick in 2014 and 2015. Likely related to a number of Affordable Care Act implementation issues and also a number of expensive drugs coming online. And then for the last 2 or 3 years, cost growth has been more restrained. So this chart summarizes that recent history. This chart, now we start to look at the components of total healthcare expenditures and kind of the varying contributions they make to how much spending growth has changed. So this looks at it from the perspective of the different types of payers, the health plans that pay for healthcare. So you see the largest component at the bottom is commercial insurance, and you see that there was a 3.3% growth rate. The second largest component in the system is Medicare, and that grew at 5.7%. That's significantly faster than last year when growth was below 3%. And we can talk about that more if folks want to. And then Mass Health, you see essentially neutral, no cost growth, only 0.4%. There were significant program changes happening in Mass Health during 2018, which we will talk about a bit in further slides. This is an interesting breakdown because this is, instead of looking at it by the payer, this looks at it in terms of the service categories. So this shows where the money gets spent, the types of services that are purchased. So you can see, and starting from the kind of the building blocks at the bottom, hospital inpatient grew by 3.7% to 11.7 billion. That's the largest component of spending, and it's, I think, the first time that hospital inpatient spending has exceeded the benchmark in a couple of years. The growth there had been kind of restrained for a few years, but in 2018 it accelerated a bit. Hospital outpatient was 3.8%. The next component is pharmacy. We've this year tried to do a better job of looking at pharmacy spending in terms of both gross and net. The data book and the annual report has a much more information on this than just this presentation does. But you can see on this slide, it shows the amount of spending on pharmacy, the full amount of gross, and then the hatched lighter blue shows the amount that is rebated, so kind of the net amount of spending if you account for rebates. And then the increase in spending, instead of being 5.8%, would be 3.6%, accounting for rebates. Other things that are noteworthy here, I guess, other professional services grew by 8.4%, which was a fairly significant growth. And I think that's it. Okay, so turning to Medicare. Medicare is a slightly smaller part of the system than commercial insurance, which was $22 billion. This is $18.1 billion. As I mentioned, expenditures were up 5.7%, so that's rather brisk. Historically, Medicare has been quite a bit lower than that in recent years. And Ashley, do we do any thoughts on that? Is this mirror national trends? I'm trying to remember.
So our expenditure growth was higher than the national Medicare trends, and unfortunately, this is a very aggregate data source, and Medicare is, of course, one of the areas where we have the fewest policy levers that we can pull. So sort of leave that up to the commission. That's my 2 cents.
All righty. Thank you. Okay, and looking at it, Medicare in terms of the program components, you see that in Massachusetts, most people are still in traditional Medicare, and that grew somewhat less quickly than Medicare Advantage, where there's about 20% of the population enrolled in Medicare Advantage. Turning now to Mass Health, as I mentioned earlier, spending was essentially net neutral. It went up 0.4%. Membership declined by 4.4%, and there were significant program changes happening as the ACO program came online, and I think it's about 60% of Mass Health's members converted from managed care or other types of payment structures into ACO programs. So this looks at Mass Health at the programmatic level a little bit. It breaks down kind of the prior numbers. You see the, I guess the first thing to point out is that the boxes that are circled by the orange dotted lines, that represents programs or members that have been converted from one form of coverage in 2017 to the ACO program in 2018. So the programs themselves have varied quite a bit, but it's essentially the members from those 2 programs on the left have migrated over to the 3 programs on the right. Ashley, is that captured, or is there anything you can add to that?
Yeah, so I think something that we tried to show here that may or may not come through on the graph is that it's difficult to compare these 2 years where we're looking at the members in the MCOs in 2017, and then in 2018 we're comparing them to the managed care organizations and the ACOAs, which were administered by payers. So it's a slightly different population from year to year. But if you look at what's in the orange dotted box, those are roughly comparable populations.
It's not really different populations. It's just different service construct.
Okay, thank you.
And actually, what you should do is take the 1.9 billion and the 4.5, and that would give you sort of a comparison of the 4.8 billion in the MCO book of business to the ACOB and the MCO book of business.
All right. Moving on from mass health to commercial insurance, which is $23.3 billion of the system. Expenditures increased from 2017 to 2018 by 3.3%. Historically, the commercial market tends to be right around the benchmark. We've seen more variation with Medicare in the past few years. Commercial has been generally right around the benchmark, or right around 3%, or a little bit over 3%. A slight decline in the number of member months covered by commercial insurance in 2017 to 2018. Looking at the commercial insurance market in terms of the product type, you still see that about half of the market is in HMOs, where spending increased at a rate of 4.2% year over year, from 9.7 billion to 10.1 billion. PPO, a smaller part of the market, but still substantial. Spending growth increased from 8 billion to 8.4, a 6.2% increase. And those are the major components of the commercial market by product type. Another thing that we look at in the annual report is the adoption of alternative payment methods. And there's more materials in the annual report, but this slide shows some of what you see in terms of the number of covered lives under alternative payment methods in different product types. So you see for HMOs, 2017 to 2018, and this is true across the different product types, a slight decline in the number of lives covered under alternative payment methods. So it's been a few years now since we've seen any significant growth in the commercial market for alternative payment methods. Of course, mass health, there's a significant amount of growth there. But you see that in the commercial market, it's mostly HMOs that have adopted alternative payment methods, and the different colored bars reflect the dark blue being global full budget, so a full global budget for the patient. The lighter blue being a partial global budget in which either pharmacy or behavioral health or some other component has been carved out. But that shows that global budgets are the dominant form of alternative payment method as opposed to some of the other options that are available. And then the slide shows the relative adoption across the other insurance market types. Ashley, anything further on this one to note?
So one note that I would make on this is that as we think about alternative payment methods as a ways to encourage providers to manage a member's care and coordinate care throughout the healthcare system, to the extent that payers are implementing global partial budgets where certain services are carved out and that the provider is not responsible for those, you may see some discoordination of care because of that.
One more slide that looks at the adoption of alternative payment methods. This is among the largest medical groups in the state. The proportion of their, there's subtleties to this, so I'll probably get it wrong. So actually be prepared to correct this. But essentially, these are the proportion of their member months whose care is attributed to these managing physician organizations that are under alternative payment methods. So you can see, for instance, Partners and Atrius, the two at the left-hand side, have essentially 95% of their attributed member months in alternative payment contracts. Less so at some of the others, much less so at UMass, and I would imagine even much less so at smaller medical groups, and that's why overall statewide adoption isn't as high as what we see in terms of adoption at the major medical groups. But other thoughts on this, Ashley?
Yeah, so we do hear from both the payers and providers that they need a certain critical mass of members in any one provider organization in order to appropriately take on these alternative payment contracts. And then the other thing I'll say is that the universe that's being portrayed in this graph is, as Ray said, members who have been either assigned to a PCP or attributed to one in an HMO or PPO product. And of course, many PPO members may not have a PCP assigned or attributed to them. And so those members would not be present in this graphic.
Great. attempting to move on. There we go. Okay, so you can think of alternative payment methods. I mean, as a way, that's how health plans are trying to influence the way provider organizations treat patients. Another way of getting at healthcare utilization and trying to control costs is by changing the way patients interact with the system. And so that's typically done through benefit designs. So this slide takes a look at the adoption of different types of benefit designs in the Massachusetts insurance marketplace. And it's pretty striking. What you see is limited network plans at the bottom have remained very flat over the last 3 years, only 5.3% of the market. Tiered network plans are somewhat more prevalent, but still relatively flat, having moved from 19.2, 18.8 last year, up to 20%. I should mention, I believe the GIC is a major player in the tiered market space, and so if you took them out of this, you would actually see a significantly less adoption of tiered networks as a benefit design tool. And then really the most striking one is the top line, which shows the continued strong growth in high deductible health plans, where they're now at 31.5% of the market, so closing in on a third, which is a significant fact that just needs to be dealt with in terms of a number of different aspects of healthcare policy. This slide takes the high deductible health plans and breaks it out by market sector. And so you can see that it's clearly, I mean, there's a direct association between the size of the purchaser and the appeal of the high deductible health plan. But even among jumbo groups, it's 24.9% of member months are covered under a high deductible health plan. And for unsubsidized individual purchasers, it's 80.2%. So really broad adoption, regardless of the purchaser size, but obviously more so at the smaller side of the scale. Okay, well, so this, and not unrelated, and so this now turns to, and we've, other speakers as well, the speaker and others have commented on the issue of affordability, which is, probably becoming more of an issue than the flat-out top-line cost growth numbers. And this chart, I think, really brings home some of that. So what you see, I'm going to have to look at my version so I can read some of the numbers. There's just a direct correlation between the amount of out-of-pocket expenses and essentially this purchaser size division. So what you see is unsubsidized individuals who are the highest adopters of high deductible health plans. They're spending roughly $93 per member per month, or just over $1,100 per year in out-of-pocket costs. So if you think of a parent and 2 children, that's $300 a month, or over $3,000 a year in out-of-pocket costs above and beyond premium costs. And then, as you can see, this goes by a small group, they're spending $79 per month, mid-sized group $65 a month, till you get down to jumbo groups, they're only spending $50 per month, or about half as much out-of-pocket as unsubsidized individuals. The connector, there was a significant change that I can't do justice to, so I'm going to ask Ashley to do that, but where there were some federal changes that really pulled the rug out from underneath the program in some ways, and we very smartly adapted to those changes in a way that really held individual purchasers on the connector harmless. So Ashley, can you explain a bit of what happened there?
Sure. So in October 2017, the federal government ceased payments of cost-sharing reduction subsidies, which were one of the components that allowed Connector Care to provide members with greatly reduced cost sharing. Connector Care members, of course, are low and moderate income Massachusetts residents. And Massachusetts, as many other states did, permitted the insurers to use a tool called silver loading to basically increase their silver tier premiums in the individual market to compensate for the loss of these cost sharing subsidies. And we have a nice graph in the report that shows that the takeaway from this was that as the silver tier premiums increased, the federal premium tax credits also increased to compensate. And so for Connector Care members, their costs remained essentially the same, and the plan still got paid, and the state paid about the same as well. It was just that the federal subsidy changed from being a cost sharing reduction subsidy to a tax credit.
Impressive. Thank you.
I'm sure the Connector has more information on that as well.
All right. But so anyway, so this really does, the affordability issue, this slide goes to very much to the heart of it in terms of out-of-pocket experience of people. And these slides we're looking at, these are all related, these three in a row, the adoption of high deductible health plans, the out-of-pocket costs, and then here you see fully insured premiums, once again by group size. And so here, you're seeing more expenditures at the larger size group sizes, but that's a reflection of richer benefit designs by and large. So that would also tend to translate into lower out-of-pocket costs. And so there's a number of factors that are driving, people that are not in the larger groups are more likely to be in high deductible health plans or otherwise be exposed to out-of-pocket costs. Are there other things about this slide? Actually, I'm trying to remember.
I would just say again, you'll see up there a 22% increase in connected care premiums, but again, that was the underlying premium. From the members' perspective, they did not see that increase.
And this is an important slide also. This is one that we've shown before, but this kind of, is the bottom line, if you will, in terms of the cost sharing increases. This shows over a 2-year period the increase in cost sharing, the out-of-pocket exposure of individual members compared to premium growth, which is also a high number, over 10%. And then you see regional inflation, wages and salaries, and even claims paid by payers and self-insured employers, all at a point on the graph that's significantly below the cost sharing and the premium numbers. So that again points to the fact that individuals are having a different experience of the costs of the system than the overall 3.1% number might indicate. The next slide or two take a look at premium retention by market segment. We do, the net cost of private insurance in one of the earlier slides where we break out the components of spending, that was up by 11 some odd % this year, second year in a row that it's been up by double digits. So we wanted to have a couple of slides to take a closer look at what's happening in terms of premium retention by the health plans. Do you want to take Ashley, I think this is, your.
Yep. So as you saw in the previous slide, over the past 2 years, there's been a real gap in terms of the difference between premium growth and the growth in claims costs that the plans are expected to cover with those premiums. And what's left over when they've paid out their claims, that dark blue sliver of the pie chart in the bottom left-hand corner of this graphic is what we call premium retention. And premium retention is used by the plans to cover their administrative overhead, to pay broker commissions, premium taxes at the federal and state level, and then whatever is left goes into their reserves to protect against losses in future years. And what we saw over this time period is that there were significant growth in premium retention in the merged market. We saw a 22.5% increase from 2017 to 2018. But even among larger employer groups, there was nearly a 14% increase year over year. And we don't think that Massachusetts is unique in this. The national trends are also showing that plans are bringing in more revenue and more profits across the country. And so I think, this is certainly something that the Commonwealth should be monitoring. I don't think it's something, I think there are policy mechanisms in place already that help protect consumers because of course we have the medical loss ratio regulations administered by the Division of Insurance. And those ensure that a plan can't keep more than the admissible percentage of premiums for their retention. And we know that in previous years, only a handful of payers have had to pay these out. So I think, what we're saying is that retention has been increasing. It's something that we should be paying attention to. We should be looking at administrative costs, but we should also, trust that the MLR regulations are going to protect consumers.
All right, so moving to the last slide, also on premium retention. This looks at the components of premium retention. This is specifically for large, again, since you're sort of, why don't you take this slide as well, Ashley?
So these are looking at the larger employer groups with 50 or more employees. And what we see here is that the percentage of premium retention that was spent on things like administrative costs and broker commissions decreased over time, but we don't think that's because they were spending less on these areas, but more that the overall retention pie slice was growing from 2016 to 2018. And I think what's really striking here is that bright blue 21.5% of premium retention in 2018 was payer surplus. And I will caution here that this is less than 3% of their total premium revenue. So it's a 21% of that little pie sliver right there. But it is a notable growth, whereas we were seeing in previous years, even if you extended back beyond this graphic, payers were sort of just breaking even or making small gains. In the past 2 years, we've seen substantial gains for payers.
And I believe that's our last slide, yes. So if there's any questions, happy to take them. Otherwise,
Ray, I'll jump in. On the mix of group sizes for the employers, is that all from fully insured data, or does that include some self-funded data?
So everything you'll see here, except for the premiums of the premium retention, all of the other slides include self-insured employers as well. So when we're looking at cost sharing and high deductible trends, that includes both fully insured and self-insured.
So the
accounts.
23 billion top line is both fully and self.
yes,
What fraction of commercial insurance is self-funded?
it's just over half.
Yeah, it's about 60%.
Ray, can I ask you about the use of alternative payment methods? So what these show is that, for example, if I go to a physician who's employed at Partners, that the odds are that that person is in some kind of alternative payment methodology. But yet we also know that referrals to the big teaching hospitals are very high. And if anything, they're going up or basically being about the same. And many of those referrals are from people who might be in a different ACO contract, not the downtown teaching hospital one.
Yeah.
So there's an issue, which is that for a lot of the medical care, even though the patient is in some kind of alternative payment methodology, when they actually go to use the services, particularly the expensive services, are being paid for still on a fee-for-service basis. Can you track that and say anything about what's happening overall to the share of dollars that are paid where that dollar is by a provider who's at risk for that patient?
I think unfortunately, no, this is a very aggregate data source. I would love to have that data though.
Yeah, I think we don't. I don't know if it would be possible using the all-payer claims database and some of our other analytic assets to see if we could get at it. My staff is listening to this presentation. We'll take a look at that question and send you an email.
Okay, thank you.
Thanks a lot, both of you. It's great work. Two questions. The 4.4% reduction in Medicaid enrollment, who are those people and where did they go?
Generally, I defer.
They went to the connector.
So they're commercially insured now.
That's what I said, yes. We work very carefully to make sure that our numbers are very completely consistent and interlocked perfectly with Mass Health, but then really they're the deep dive experts on their own population. And so, yeah, I think that's essentially what we see in the data as well, is that they.
Right, the data is basically, it's the churn between, on the income side, so people going between Mass Health and the connector, and sometimes from the connector back to Mass Health, depending on one's income. So it's pretty fluid, actually, and it works pretty well with the HICS working.
Thanks. And the cutoff for high deductibility is $1,350. Is that the definition?
I think
Yes.
13, yeah.
Yes, that's correct.
What is the distribution like? Like, can you give us some idea, or maybe there's a graphic that shows how much exposure there can be and what the percentiles look like?
So I unfortunately don't have that in front of me. We do have a page in this year's report that was new for this year that shows we did some surveys with payers to get some qualitative measures, and we know that the distribution of deductible levels shows that many members do have deductibles substantially above that threshold of $1,350. And what we saw was that over the 3-year period we looked at, there was a substantial increase in the number of members with higher deductible levels and higher maximum out-of-pocket levels. So we do have that in the report.
Thanks.
Other questions? Yeah, I just want to follow up. That 50% self-funded, is that stable? Is it going up or down? Is there a trend for the number of employers that are self-funding versus
My understanding
fully?
is that self-insured has been growing.
By a little or a lot?
we've seen modest growth.
I mean, I thought it was around, I mean, it's trended from 50 up to 60 over the last 5 or 6, a couple percentage points a year, perhaps, that type of, slow growth, but it's adding up.
And if you go to the last slide again, in the gain and surplus, that only represents fully insured, right?
Yes, correct. That's
Because-
only fully insured.
Okay.
So I'm going to go back to the, since apparently we're using mechanics and going under the hood analogy throughout this morning, which is ironic since I wouldn't know what a hood of a car looks like. But having said that, so the good news is we stayed under the benchmark, right? But as you then sort of look and dive into those numbers, and this may be an unfair question, so you can pass on it. Medicaid represents about a quarter of the total healthcare expenditures for the Commonwealth, and it was flat.
Right.
So if Mass Health, say, was 2 or 3% growth, what would that have done to the benchmark?
Right, we just barely made the benchmark with Mass Health at a 0.4% increase. So clearly, I mean, commercial was 3.3 and Medicare was 5.7. So we'd be somewhere in the 4% range if it wasn't for Mass Health's performance.
Questions?
Great, thank you.
You're welcome.
Thank you.
Thank you
Thank
very
you
much.
very much for all you
Thank
do.
you.
And Ashley, thank you as well. Mary Lou, would you like to introduce our next speaker?
We have an unknown speaker now. I'd like to welcome the governor. To the seventh, so this is our 7th cost trend hearing. It is my honor this morning to introduce the 72nd governor of the Commonwealth of Massachusetts, the Honorable Charlie Baker, well known to the healthcare community in Massachusetts and in government, of course. As everyone knows, he is a prior cabinet official under 2 former governors, having been the Secretary of Health and Human Services and the Secretary of Administration and Finance. For 10 years, served as the CEO of Harvard Pilgrim Healthcare, and was successful in his first run as selectman in Swampscott.
All politics is local.
I know that. It is my privilege to serve with him as his Secretary of Health and Human Services and to have him with us this morning. Good morning, Governor.
Morning, Madam Secretary. To the members of the commission, thank you very much for hosting this hearing and engaging this discussion. I also want to thank Ray Campbell for his leadership in ensuring that CHIA continues to achieve its vital mission to serve the unique role as the hub of information and analysis about the Massachusetts healthcare system. And my appreciation to our colleagues at the Mass Health Policy Commission, specifically Stuart Altman, who I've known for many years and I know wishes he could be here today, to Marty Cohen as well and the entire board, and to David Seltz and the staff for having me over. The cost trends hearings are an opportunity to convene healthcare leaders, policymakers, and experts to discuss challenges and opportunities to improve healthcare and reduce costs here in Massachusetts. Our administration is committed to serving as a partner in advancing your mission to advance a more transparent, accountable, and innovative healthcare system. As you probably noticed, we filed a pretty comprehensive piece of healthcare reform legislation last week, which I'm going to talk a little bit about. First part I'm going to talk about is contextual, just to give you some idea about why we chose to do what we did. For the past 50 years, the U.S. healthcare system has been focused primarily on promoting and supporting the technological advancement of medicine. That focus has cured disease, enhanced therapies, and saved lives. However, we failed to appreciate the changing nature of illness and the systemic gaps in care delivery that have been created by this approach. One need look no further than the opioid epidemic to understand what we have missed. The overprescribing of addictive and potentially deadly pain medication brought on by a system in which it is more financially beneficial to write a prescription than it is to provide supportive sustained therapy created an addiction epidemic of gargantuan proportions. While many would argue that the fundamental problems with our healthcare system are rooted in some provider organizations being paid too much and some being paid too little, we would argue the problem is more fundamental than that. Our healthcare system rewards those providers that invest in technology and transactional specialty services at the expense of those who choose to invest in primary care, geriatrics, addiction services, and behavioral health care. This is problematic for 3 reasons. First, the nature of illness is changing. Chronic illnesses are far more prevalent than they used to be, in part because of the success of modern medicine in solving many acute illnesses over the past 5 decades. Second, we're an aging population. Many of us who live to an age where brain diseases are far more common, again in part because of our success in treating disease. And third, for a variety of clinical and sociological reasons, mental health addiction and behavioral health issues are far more challenging than they were in the past, and we increasingly recognize how they are intertwined with physical illness these days. Meanwhile, the primary care shortage that was identified over 30 years ago has gotten worse. Simply put, the care delivery and financing system we have today is not designed to take care of the people and the patients we have all become. We pay for a system that's built on transactions and technological advances, not on collaborative care delivery and/or therapeutic support. While technological advances remain a critical component of delivering effective health care, a 21st century healthcare system should presume that collaboration and time are at least as important as technology, and that for many people, physical and mental health are related. It should reward providers and provider organizations that invest in a comprehensive set of physical and behavioral health services and understand that population-based health management requires time and connection. Solving this problem at the state level is complicated by the overarching role played by public and private national payers in healthcare in this country. For the most part, national payers, including Medicare, use payment policies that favor technology and transactional medicine at the expense of primary care, mental and behavioral health and addictional services, and ironically, geriatrics. Almost all providers and payers build their financial models and their operations using this fee schedule as their baseline. This makes any decision to deviate from that model, for example, to offer more mental health services, extremely hard to do. Federal policy and research funding also drive provider organizations to focus on specialty services and care instead of on addiction, mental health, or behavioral health, primary care, or geriatrics. This makes it financially difficult for any care delivery organization to double down in the areas where the greatest gaps in the existing care delivery system exist. The legislation we filed on Friday is designed to do many things, but one of them is to create a positive financial incentive for healthcare providers and payers to rethink their service delivery and investment decisions. The bill encourages providers and payers to invest in behavioral health, addiction, recovery, primary care, and geriatric services that are underfunded by today's payment models, incorporate these services more directly into care delivery strategies. Our legislation targets those challenges by requiring investments in behavioral and primary health care and establishing a statewide spending target. Providers and insurers, including MassHealth, will be required to increase spending on behavioral health and primary care by 30% over 3 years. Calendar year 2019 spending will serve as the baseline, and providers and insurers will be measured on their performance in calendar year 2023. Providers and insurers will be required to report annual progress through the frameworks that involve our partners at the HPC and at CHIA. If the target's not achieved, providers and insurance will be referred by CHIA to the HPC and may be subject to a performance improvement plan, which may require them to identify strategies to increase investments in primary care and behavioral health. The legislation proposes these increased investments in primary care and behavioral health while requiring overall spending to stay within the parameters of the state's overall healthcare cost growth benchmark. Understand the importance of the process that exists here that continues to control costs on a global basis. This will be a break from the trajectory of the past several decades and may cause some modest disruptions. But it's the right direction for our payment systems and providers if we want to create a payment and care delivery system that serves our people in the most cost-effective and appropriate way possible. Our bill also builds on the foundation laid by the 2012 cost containment legislation. As we heard earlier, recent efforts have yielded moderate success in bending the healthcare cost growth curve. However, rising healthcare costs disproportionately affect individuals and employers as increases in premiums and cost sharing continue to outpace overall expenditures. To address year-over-year increases in pharmacy spend, the legislation seeks to hold high drug cost manufacturers accountable through a similar HPC framework for payers and providers who exceed the benchmark, to penalize manufacturers for excessive price increases, and establish new oversight authority of PBMs. By the way, something that's present in more than half the states in the United States. The bill also includes several consumer protections and measures to reduce consumers' out-of-pocket costs, including prohibitions on surprise billing practices and facility fees, and reforms promoting access to more affordable, innovative health plans for individuals and employers alike. The bill also requires accurate provider directories for consumers to secure behavioral health appointments and for pharmacists to always offer the lowest cost available prescription. Further, a stable and affordable insurance market is key to maintaining our near universal coverage levels and a well-functioning healthcare system. To address many of the emerging federal policy changes and the dynamics that may impact the Massachusetts merged market, last Friday I also signed an executive order establishing an advisory council to conduct an independent actuarial analysis of the merged market and provide recommendations by April of 2020. Finally, this legislation promotes access to quality, coordinated care and modernizes policies to bring Massachusetts in line with other states and areas where we've lagged. These measures include removing outdated practice restrictions for mid-level clinicians, creating a new mid-level dental therapist, standardizing urgent care services, and advancing telemedicine through aligned regulatory and coverage policies. It would seem to me that since we invented telemedicine, it's probably time for us to legalize it. Managing excess costs and promoting increased access to vital services will support the recalibration of our healthcare financing and delivery system toward a model that values time and positive outcomes and meets the evolving needs of our patient population. Many of the reforms we propose will also reduce costs, including to patients and small businesses, while maintaining the quality of care Massachusetts deserves. We're grateful for the opportunity to collaborate with the HPC and look forward to a productive dialogue with you and with our legislative colleagues as this conversation on this bill and others moves forward. Thank you.
Thank you, Governor. Any questions for His Excellency? I'm not hearing any. Again, thank you.
By the way, I appreciate the fact that Secretary Sutters brought up the growth rate in the Medicaid program.
Yeah. Well done.
Thank you.
David?
You done?
Okay.
Yeah.
Well, that must mean you plan to talk to me a lot about the bill once it gets into the process, which is fine with me. Thank you.
We do. Thank you.
Thank you.
Governor, thank you so much for being here and sharing your bold vision for healthcare in Massachusetts. The comprehensive approach that you and Secretary Sutters are proposing, as you said, builds on the strong foundation that was established 7 years ago and sets new goals for healthcare access, quality, and affordability, especially with regard to primary care and behavioral health care, and as you said, geriatric services. And thank you, as always, for your trust and confidence in the HPC. Consistent with our core mission, we're ready to take on new responsibilities that will help our healthcare system deliver better health, better care at a lower cost for everyone in Massachusetts. It is now my honor to welcome two distinguished healthcare researchers and thought leaders to the witness panel. Dr. David Auerbach, Senior Director for Healthcare Cost Trends and Research at the Health Policy Commission, and Dr. Meredith Rosenthal, the C. Boyd and Gray Professor of Health Economics and Policy at the Harvard T. Chan School of Public Health. We're going to continue briefly this morning with more of our fact foundation. And Dr. Auerbach is going to build off of the presentation that Ray and Shia provided earlier with some new research and data comparing the Massachusetts experience and performance with the rest of the United States. He'll also offer some further insights into affordability challenges facing many Massachusetts residents. Dr. Meredith Rosenthal will follow with her own insights on opportunities to drive value in the healthcare system. Commissioners, they will both pause after their presentations, but don't be shy about asking questions throughout, as you never are. So with that, David, you're up.
Great. Thank you, David. Good morning, everyone. Morning, David. I will attempt to put some of the numbers we saw from CHIA earlier this morning into a national context and in terms of longer time trends as to how we've been doing over the last several years. And following a similar pattern, I'll start with overall growth, talk a bit about Medicare, and then into the commercial market. So this graph shows the overall trend over the last almost 20 years now of spending growth per person in Massachusetts compared to the rest of the country. And as we see a couple things here. We see that, again, we continue to be below the national growth rate, just barely, in 2018. And we do see a similar pattern reflected, as Ray noted, in 2014 and 15, higher growth with the Affordable Care Act and somewhat lower since then. The 2018 US data point is still preliminary, so we'll see in December when that finalizes. There we go. Okay, so this slide is showing a little more detail on what we saw was a faster growth in our Medicare spending in Massachusetts last year. It was indeed faster than the rest of the country. And this breaks that down by category of care. And we see where did we grow more quickly. You see a bigger difference there in the hospital inpatient category. We grew faster. Hospital outpatient spending was higher across the country, slightly higher in Massachusetts. And those really dominate the trends, a little bit more in home health as well. And we'll come back to hospital spending in the rest of this presentation. And that faster growth, where does that leave us in terms of the levels? Here's just a comparison now in 2018 of how much we spend compared to the national average for our Medicare beneficiaries. And again, you see higher spending per person in hospital inpatient and outpatient care, lower spending in physician and other professional care, and again, the big difference in home health that we've talked about before. So this picture suggests that we have a more hospital-centric care delivery system than other states. This slide it furthers that. This is showing the number of inpatient admissions per capita in Massachusetts. Again, we've known that we have more hospital use than the rest of the country, and that continued in 2018. We had a slight drop. We haven't seen the national data yet, but that gap remains. Despite the fact that we are a relatively healthy state, we do use the hospital more. We also continue the trend in having a higher rate of readmissions for our Medicare population. On the top line is the Massachusetts Medicare readmission rate, 18.3%. This is 2017 data. And in the US, 16.8. So we have grown while the rest of the country has pretty much been flat. And we're now the second highest after West Virginia in terms of our Medicare readmission rate. Our all-payer rate has also inched up in the last few years. One bright spot that has continued concerns post-acute care. Our rate of discharge to institutional post-acute care, which is mostly skilled nursing facilities, dropped again in 2018. That's the orange line in the bottom. So that is coming closer to the national average. Our home health care use is increasing the spread with the national average. We continue to be very high, and it looks like this is mostly a shift from skilled nursing to home health. Okay, so the rest of the slides will be mostly about the commercial market. Here, parallel to the first slide I showed, our commercial spending trend continued also to be below the national average in 2018. And you see the line of, since the HPC was established in 2012, that has been true every year. So this is a positive trend, although as you'll see later, these data points measure commercial spending and they don't include the aspect of premiums that's called retention, those administrative costs, which Chia explained, and we'll come back to that. Okay. When we ask the largest three payers of what is driving that commercial spending growth that we do have, over the last 3 years, continues to be mostly a story about price compared to utilization or provider and service mix. We see, as always, a wide variation in commercial spending based on where your primary care physicians are. That gap is about $2,000 from the most expensive group to the least expensive group, again in 2018, with the average growing each year. It's a combined spending growth total of 24% from 2013 to 18.
David, these don't include self-insured, or they do?
This is a snapshot of the universe that's self-insured are included in there. This is based on the patients that can be attributed to a provider group, the managing provider group. So yes, they are in here. Okay. Now coming back to inpatient care, which was an area of growth that Ray noted this past year, we see over the last 5 years that commercial inpatient spending has grown each year, despite the fact that commercial volume has dropped each year from 248,000 discharges to 217,000. So you would think this might be an opportunity for some savings, but again, despite the fact that volume has dropped each year, spending has continued to increase each year. And that amounts to a growth in spending per discharge of 5.2% per year, from 14,500 per discharge to 18,700 per discharge by 2018.
David, what percentage of the volume that went down is related to folks in high deductible policies?
Oh, that's a good question. I wouldn't think very much. High deductible plans won't affect hospitalization rates nearly as much as ambulatory care and other aspects. Yeah.
And
Good question.
is the inpatient growth even across systems, or is there certain hospital systems that are doing more or less inpatient? This is looking at it holistically. I'm just wondering, system-wise, are there some that are doing less than others?
We will show a breakdown of community hospitals versus the others coming up next, but if you want to think system by system, there are some differences that we're not showing today, but for example, you see differences in numbers of beds and occupancy rates and where care is being delivered, and you see differences in prices and spending. We'll talk much more about that in this year's cost trends report.
Great.
And we'll get back to you. Okay.
But I suppose the question,
Yeah.
sorry, I'm just playing off some of these. I suppose some of the question is, given what you showed us earlier, do you think we should be worried? That is, okay, there's a new trend happening and we're going back to more inpatient stays, and this, if they're not absolutely necessary, this is problematic and so on. Or do you think that what we're seeing is sort of a blip and, look, in this 1 year there were more people who were sick, or there were people who had particularly intensive diagnoses and so they wound up in the hospital, but overall we shouldn't really worry about that. I guess I'm trying to search, I don't know if Ray, you want to weigh in on this either, how we should think about this one.
Yeah. We are dissecting this, and we're learning a lot this fall on the inpatient side. And again, we'll have more to say in the cost trends report. But we can break those discharges down into maternity related, which are dropping a bit. People are just having fewer babies year after year, versus admissions from the ED versus a scheduled admission. And you see different trends there. For example, the admissions from the ED are what are not dropping. The other categories are. We looked a bit about this last year. What's going on with admissions from the ED? There's variation in the admit rates. Some of them, there's some discretion in some categories, but I don't have a simple answer to it, but it's definitely something that we're learning more about, and I think we should continue to focus on.
So it may be that later this year when we talk about our cost trends report, that we'll want to come back to it then.
Or I would suggest our panelists might have some insights.
Panelists might
Yeah.
have some insight.
Great. Okay. So here we're showing the full picture of admissions by payer. As we noted, the commercial admissions are dropping. They used to represent about a third of all volume, and now it's down to 28%, whereas Medicare admissions have grown and made up the difference, so that now getting close to half of all hospital admissions are Medicare paid. And when you look by category of hospital, here you see that the community hospitals have accounted for about 53% of all admissions, and that's been pretty steady from 2010 to 2018. Although interesting is they are receiving a slightly declining share of all births and a declining share of the higher paying commercial discharges over time, especially in the last few years. So that's an important trend that affects their finances and other things. This slide, I won't spend a lot of time on it. It's a busy slide, but it's a little detail on the APM story that Ray noted, where the penetration of alternative payment methods has not grown the last 2 years. We wanted to understand where is the growth stopped and what's going on with that. And the takeaway here is that we've divided the payers into categories, and you see those other mass insurers. The orange bars are showing, of all their HMO members, what percent are in an APM. And you see that drop 40 to 36 to 29. So that has really caused the overall reduction in APM penetration there. And those are insurers such as Always, Fallon, Health New England, and so on. It hasn't dropped among the large 3 insurers, though. Okay, so now the last several slides, let's talk about premiums and affordability. So as I have shown this before, we're showing individual premium, total premium costs for mass employers in the top orange line and for U.S. employer coverage in the blue. We had been closing the gap with the rest of the U.S., and in the last 2 years, we really haven't, and it's widened again. And that's as Ray showed on his final slide. Premiums have grown 5-6% for each of the last 2 years. So we've eroded some of those gains. Our single premiums are the 7th highest in the U.S., and that is still in contrast, large contrast to the connector, where we remain the 2nd lowest premium in the U.S., and that's up into 2019. So the gap between our single employer premiums and our connector premiums is the biggest in the country, and it's very large. Turning to our employer-based premiums, and these are very big numbers. Employer premiums are now around $20,000 a year, as Kaiser recently reported on average. And here, I've averaged 2016 to 18 to have a more robust number. We're the 3rd highest in the country, over $20,000 a year. And those orange dots, well, the dots above, show the 90th percentile of those premiums, the level at which 10% of all people with employer coverage pay more than that. And our dot there is at around $30,000, along with Alaska and New York, meaning that 1 in 10 mass residents with employer family coverage is facing a $30,000 a year premium or more. That's more than a lot of people's salaries, as we know. So putting it all together in a way, when we take that high premium growth and that high level of premiums, and we look at earnings gains for the last 2 years for Massachusetts families with employer coverage, more of that increased earnings went to health care than went into people's pockets that they could take home and spend on everything else. That orange part of the dollar is $277 in increased healthcare spending for a family between 2016 and 2018. When you take all the rest of that earnings gain, you see 165 going to taxes and 270 taken home for spending on everything else. Healthcare accounted for almost 40 cents of the dollar.
So David?
Yes.
So there's another troubling trend out there, and which I'm sure is not captured in here, which is that employers are starting to charge a surcharge to their employees if they elect to cover their spouse or domestic partner, and if that domestic partner or spouse has coverage in their employer. And some of these are up to like $600 to $1,000 a year out of someone's paycheck. I'm not at all blaming employers who are trying to do everything possible to keep their healthcare costs down, but I think that is something that HPC and others should start to try to wrap their arms around, because I would argue that it's a hidden cost that wouldn't show up in this.
That's interesting. Okay, we should try to track that. I'm not sure if GIA picks that up in the employer survey, but no?
Well,
Okay.
I don't know if they do now. It might be a question to ask going forward.
Yeah, not now, but.
David, can you just
Yes.
do a quick calculation in your head? So the 270 take-home increase in 2 years,
Yes.
wage inflation in that period of time, were they a net loss or a small net gain in take-home pay, do you think?
This is a gain. I mean, the wage increase was about 6%, $7,000 over this time. So this is combining people's increase in wages and the additional amount those employers paid for health insurance premiums, and then the employee portion of the premium is shown there too.
But in many ways, it's even worse than this because this is mean wages, and that's not what the median family is receiving, which will be below this, actually. Whereas the health costs are likely spread across everyone.
They're spread across, right. And it also could be worse in that the wage increase is over all families with, in the state. Whereas employers are often forced to make a trade-off of, if I'm making higher premium payments, I have to lower your wage increase. And so some of that is not represented here as well. Okay. And so when you add it all up, what is this median family paying, and where is their healthcare spending going? This is accounting for that. The total amount that average Massachusetts family with employer coverage is paying is over $2,000 a month in 2018. And you see that increase there. And we can ask where that money is going. About $220 a month is paid in deductibles and copays. About $282 is in the insurer administrative costs, the retention that Ray and Ashley talked about. And that's the fastest growing category, as you see, between 16 and 18, $89 more per month. About $640 going to hospital care, $483 to physician and other professionals, and then prescription drugs, and then other healthcare costs. So one final exercise we did was we looked at a different data source and were able to ask among Massachusetts middle-class families, who's paying more than a quarter of their total income in healthcare? And we found it was about 23% of these middle-class families, and we called them high-burden families. And then looked at some characteristics of these and found they were different. They were different than the low-burden families or than everybody else. They were more likely to be non-white, about 30%, more likely to have somebody with a disability or activity limitation. Most did not have a college degree. About half were in single-parent families and more likely to be in good, fair, or poor health status. Okay.
What's the definition of a middle-class family?
Right, great question. It's difficult. So what we did was we used what's called an occupational prestige score, which folks have taken occupational categories and classified them based mainly on education and earnings and said, okay, the doctors and the lawyers are not in there. We took sort of the middle range based on the occupational prestige of the highest job in the family. And that's the category. I can show you more about that later, but it's interesting.
Is this post-tax income or pre-tax income?
This is pre-tax income, and we added in the employer premium contribution to it. So it's a look at really total compensation.
David, can you go back to
Happy
slide?
to take all questions at this point.
Slide 15?
Sure.
That's good.
Wait, I think the numbering's different.
Yeah, with regard to the connector having the second lowest
Yep.
premiums, is that attributable to benefit design in part?
It shouldn't be. It's an apples to apples comparison across the country. So, are you comparing us to the U.S. or the
Yeah, to the
employer
U.S.
to the connector?
I'm saying,
Yeah.
is...
We have the same benefit design, and really the difference between our employer orange line and our connector orange line is, it used to be somewhat about benefit design, but now with the silver loading, they're actually more comparable in terms of benefit design. Most of that is due to, well, we're going to spend a lot of time trying to figure out that gap this year. But my sense is a lot of it is lower payment rates to providers. You have BMC Health Plan and Tufts Public Plan are the dominant payers in the connector, and they tend to pay lower provider payment rates.
And what fraction of premiums are unsubsidized?
In the individual market?
Yeah.
You mean what % of members are in the
Yeah,
unsubsidized?
what percentage get a federal subsidy? What
Yeah, it's a
fraction
minority, 10-15%, I think. Most
do
people
not get a subsidy?
do not get a subsidy. Yep. They're a minority.
And do we know, do we capture the data of how much those subsidies are?
On average, CHIA definitely captures that, as does the connector. I mean, it depends on your income, but I would say on average for everybody in the subsidy range, was it about half, more than half of the premium is subsidized? Something like
So,
that.
and if you jump from the individual market to the family market, to your concluding slides, what about premium subsidies there?
Well, I am, in all of these slides where I'm showing premium cost, I'm counting the total cost. employers typically pay 70-80% of that premium. It's all coming from your compensation, but right, and the employee contribution is, is maybe 20-30%. And there are some differences there. Usually for family, they will require you to pay a higher share. Smaller firms will typically require a higher share. And I think what Mary Lou noted is there could be even some additional, machinations going on to try to get your employees not to cover your family members, because this is really hard for a lot of smaller employers to afford. And so you'll see different things going on at the edges there. Does that get at your question?
Yep. So David, I want to come back to the big picture of the overall number.
Yeah.
So, like in chapter 224, I think folks were basically given a choice, which is you can either have, you can continue to have price increases, but you've got a lower utilization, or you can keep utilization going up, but your prices have to then fall. And so the idea was they would choose the price increase and then the utilization would fall. And I think what you're telling us is that we're seeing kind of mixed evidence on the utilization part. That is, the use of formal institutional post-acute care is going down a little bit. So that's good, assuming it's patients who don't need it, but that's good. That readmission rates continue to go up, which for whatever reason we're not figuring out how to keep people out of the hospital. That inpatient rates, we're not quite sure whether that's readmissions or first primary admissions or whatever, seem like they're going up very rapidly, particularly in Medicare. So is the overall sense from this that kind of the areas that we've emphasized, we're just not seeing enough action? Like we're seeing a little bit, but we're not seeing much, and in some ways it's going backwards? Like, is that the spirit? And then, that sort of harks back, because in past years at these hearings, we've spoken a lot about things like use of institutionalized post-acute care and unnecessary admissions to hospitals and so on. And maybe that's saying we even after all of that, we still haven't figured out how to move that needle some.
Yeah, that's a good question. I guess I have maybe one more data point that supports that, in that there's a number of things we haven't shown here, but there's lots of ways to categorize avoidable ED visits, avoidable or hospital admissions. And we have some of these measures, and we will be showing them. The Commonwealth Fund compiles a lot of those measures and compares the states. They have a broad category called avoidable hospital use. We tend to do well in everything but that. We tend to do worse than average in anything called avoidable hospital use or avoidable anything. And so I don't know. I don't know if it's so much as we were doing better and now we're doing worse again. But I think the hypothesis of not a ton of progress seems fair.
Don?
Thanks, David. Sort of building on David's question, you don't have the same numbers, but slide 11 in our book, which is the comparison of commercial inpatient spending and volume. Yeah. So this strikes me as particularly key graphic, and I want to make sure I'm not misinterpreting it. So the number of discharges fell
Yes.
a lot, right? That's decreased hospital use, inpatient use.
Yep.
And the total spending went up a lot. And the only explanation that pops to mind is pricing.
Right.
Is there anything else that I'm missing here that could?
It's price and it's acuity.
It's coding. Yeah.
Which you could call coding. That's
Yeah.
right. Those are the main things that combine to that 5.2. I mean, there's probably a tiny bit in there of what I was noting. If there's a shift from lower paid community hospitals to AMCs, that could also cause that to go up. But that's a pretty minor explanation of that number.
So let me just pause on the acuity piece or the coding piece for a minute.
Yeah.
I hope I'm not, I just need to slow it down to make sure I understand it. So you could say, if I'm a hospital, I could say, well, fewer people got admitted, and the ones that didn't get admitted are the less sick ones. So the ones that are left are sicker. But that's not an acuity increase because they were there already.
Right.
right?
And-
So you
and
have to
we- and
argue
we've
that
looked at
not
that.
only
Yeah.
did the sick ones stay in the hospital, but they're even sicker than they were before, by quite a bit.
Right. I mean, we're spending a lot of time on this, and we'll have more in the cost trends report. And we did specifically evaluate that hypothesis that is the acuity going up because the less acute patients are going to outpatient or other settings, and that doesn't seem to be the case by and large. It's probably, again, a tiny contributor.
Yeah, well, just the logic that the net acuity can't go up because those patients were already in the hospital. You understand what I'm saying?
I mean, it could go up a little bit if I mechanically took the least sick patients out of the hospital and put them somewhere else, the average acuity of those who were left behind would be higher, but it would take the magnitude of what it would require to have that explain this is nowhere near what we actually see.
Yeah, that would change the cost per case, but not the total spend, if that's what all that were happening.
Yeah, that's right.
Okay, and we're going to dig into this coding issue a lot.
Yes,
Yeah,
we're
okay.
going to keep digging into it.
Other questions for David?
Just for the record, on the individual market in Massachusetts, about half and half is subsidized and unsubsidized.
About half and half. Okay, thank you.
The total.
Okay.
It's a big difference.
David, thank you.
Great. Okay.
Dr. Rosenthal. Welcome.
Thank you. Good morning. Good morning, Commissioners. Thank you for inviting me here, Secretary Setters. It's my pleasure to talk to you a little bit today about some of the price differences that David alluded to. And let's see what happens if I can find my slides. Before I start, I should note that I have the great pleasure of serving on the CHIA Oversight Council. So if that's disclosure. If I come off sounding a little bit like a commercial for CHIA data, that perhaps is my bias. So I wanted to talk to you a little bit about some work that I and some colleagues have been doing using CHIA data as a way, really, of getting into what I think are some policy issues that you've been discussing a great deal and thinking about what the opportunities are on the price side of the equation for healthcare spending. And, I would just start in reflecting after, I guess this is our 7th cost trend hearings. Congratulations, David and the Commission on once again bringing all these wonderful data to the fore. What is quite clear is that despite some success, the affordability problem continues, and I feel 100% confident in saying that 7 years from now, we will still be struggling with the same issues. Maybe they'll look a little different, and maybe the names and faces will be different on the Commission. But it seems that a portfolio approach to addressing affordability and value in healthcare is inevitably required. And so as I will talk about the opportunities to use price information to try to improve value, that's by no means to suggest that other approaches are not also needed. And in some ways, we need to think about if we use a variety of tactics, we can both have a greater impact, but also it's a way of trying to balance the unintended consequences of each, and so on the whole, do more good than harm, which I know is always our intention. So as we think again about the spending equation, as David set out earlier, we could work on either price or quantity or both to try to slow the growth in healthcare spending, or perhaps even spend less in some circumstances. On the price side, I know the Attorney General's office in their report highlighted perhaps what has been somewhat disappointing about the use of price information in healthcare policy, namely that consumers do not seem to use it very much. And when they do, the cost savings are not substantial. And I would agree 100% with that conclusion. I think you'd have to be an excessive optimist to believe that consumer-centered approaches to transparency are really going to change the marketplace. That said, I would also say that price information is foundational to many other health policies that I think can matter, do matter, and there are a number of ways that we can use price information beyond the wonderful tool that Chia has put out on the website that mostly people in the room have used. I hope. If not, get on it. But we can think about using price data on a wholesale basis, and the wholesale basis could be about targeting providers who, for example, have bundle payment arrangements, so they can understand what are the price differences for the folks that they might want to refer to. Naturally, price information needs to get to the regulator so they can understand a whole variety of important issues around competition and the possibility of concentration adversely affecting affordability. Of course, we have seen a lot of decision support tools for consumers get better and better, so not just the online search engines, but also human beings that you can call up for people who prefer a warm voice at the end of the phone rather than a search tool to help navigate those price differences. And we'll see if those approaches are more effective. I would guess that they're better, but still limited. And then benefit design more broadly, what we might call steering tools, including tiered networks, reference pricing, those benefit designs that have been used fairly frequently in Massachusetts relative to the rest of the country. And again, where there is good evidence that these steering tools, which are based on the foundation of price transparency, can save money and improve value. So when Chia put out its consumer-facing tool on its website, it also created essentially a metadata set, which includes all of the individual prices that underlie that decision support tool. In doing so, it is really ahead of the curve nationally. These data are available to any analyst who wants to try to understand patterns of price differences and potentially to develop new policies, new tools that can build on these data. The wholesale data set that we used was the first data set that Chia put together from the all-payer claims database for 291 outpatient services during 2015. Of course, they've gone and done bigger and better things since, but this will give you some sense of what we found and what kinds of analyses might illuminate pathways to affordability. What we have are median prices for every insurer-provider service combination, where we have at least 15 claims or 11 for maternity. Because of the small numbers there, for 8 of the commercial payers, making up about 3/4 of the commercial market, and more than 12,000 providers. And so we looked at the data by geography, by payer and provider, and I'll summarize a little bit about what we found. And we also did some simulations to see what would happen if a health insurance plan used the data to create a tiered network or a narrow network, or B, we had some kind of price regulation. So the measures of price and variation, first we look at the CPT, which is basically a procedure level price, and we analyze the coefficient of variation, that's the mean over the standard deviation, trying to understand how much, the standard deviation over the mean, how much variation there is relative to the average. And we compared, in some cases, acute hospital prices to other providers because we know that site of care is often a way that savings can be found, and in some cases that can improve value. For each provider, we calculated something like their average price. It's in the form of an implied price, which this thing does not like me. I'm going the wrong direction. Maybe that's the way. Which is basically looking at the services that the provider actually delivered and comparing their prices to the statewide average. And because providers tend to deliver different baskets of services, this was the most effective way we could look at the average price per provider. And we look at health service areas and the deciles of providers for the analyses that I'll show you here. And this was published in Health Affairs last week, or a couple weeks before that, and I'm happy to share with anybody who's interested. So the policy simulations we did was, first we said, well, what if a health insurance plan used a narrow or tiered network and was able to move people from the highest price providers to the 75th percentile within their hospital service area, on the one hand? How much savings would they get out of that? And then on the other hand, what if we imagined that prices were limited to the 75th percentile? So the state map here won't surprise anyone, I don't think. It shows the implied prices by hospital service area, and the dark red are the highest prices. The lightest blue are the lowest prices, and shades of red are towards the highest, shades of blue are towards the lowest. And you can see that, first of all, the amount of variation is substantial. Prices were 69 to 129% higher in the highest price hospital service area relative to the lowest. And it's not terribly surprising, I think, to see that the natural geographic monopolies, namely the islands, have the highest prices in the state, and prices in Metro Boston, of course, are higher as well. Although I think some of the patterns in the map surprised me a bit. I expected to see higher prices out west. David probably already knew that that was not the case, but this was news to me. So when we look at individual services and that coefficient of variation, so the coefficient of variation, the higher the coefficient of variation, the more variation there is relative to the mean cost of that service. And then I have services in rows here, and I apologize if the font is too small for some people. I'll just highlight a couple things for you. What we found by looking across services is that the highest variation in prices was for ambulance and transportation services, laboratory and pathology, and physical and occupational therapy. And there were dramatic price differences in each of these areas. And also we found that price variation was greater across providers within payer than within payer across providers. So that was interesting to me, and I think there's likely some signal there. And the price variation by provider and by insurer within service, they rank similarly in terms of how important they are in each group. And here I'm looking at the comparison of the average median price of these services for acute hospital settings versus other providers. And the bars above the x-axis show when hospital prices are higher, which they mostly are. The one exception is in the case of office visits, which we think is a technical issue, which is that in the all-payer claims database, it's not always easy to connect the institutional bill with the professional bill, and that's particularly difficult for hospital outpatient department visits. And so we think that we vastly understate the cost of an office visit in those acute care hospitals. But the other ratios are meaningful, particularly, again, physical and occupational therapy. It's really the PT and OT in the acute setting that's driving a lot of the variation in that context. And in this chart, I'm just trying to look at these three categories of services where we found a lot of variation in prices to try to understand how important those high prices are. And in the following sense, we look at the share of spending for each of these category of services by decile of price. So the colors are the deciles of price, and they're ranked. So the bottom decile, that lovely cornflower blue, is the low price provider. And you can see their market share is in the first bar, and then their share of spending is in the second bar. So in a well-functioning market, perhaps that's not fair, but assuming quality were the same, in a well-functioning market, we'd like to see the low-price providers getting, say, at least more than the business than the high-price providers. That doesn't generally happen here. And where it really stands out is when you look at laboratory and pathology testing, that so much of the business for lab and pathology is in the highest price providers. So this is just another way of trying to understand where might we target some policies, where are the opportunities for cost savings, and of course to ask the question, well, is there inherent value in the laboratory and pathology testing? These are largely acute hospital settings. Why are we doing that? Is that desirable? And so in our efforts to understand how much price might contribute to an affordability strategy if we used some plausible approaches, when we look first at steering patients to the lower cost providers in their areas. We basically assigned patients probabilistically to providers that were below the 75th percentile in their same geographic area, and spread them out across the very low cost ones, the middle, the not so low cost ones proportionately, as if we were creating this tiered or narrow network. And we find here that overall when we do that, we could generate for the services that we looked at here in sum 12.8% savings. Some reason that didn't go. Well, there's another piece of this that disappeared. When we looked at capping prices at the 75th percentile, not surprisingly, because we're only trimming the outliers, we get to about 9% savings. So these are just hypotheticals, and of course, many payers do have tiered and narrow networks that effectively operate in somewhat the same way. And with more data and information made available through a variety of means, other purchasers, self-insured employers, and others could assess the benefits of doing so. And perhaps these data can help spur some of those changes, which could contribute to the affordability overall among commercially insured patients. So many limitations to this work. It was intended to be exploratory and to demonstrate the value of such an approach rather than to recommend a specific policy. We're only looking at the outpatient service prices here, and we're excited to work with the additional data that are coming online through CHIA to explore some of these other patterns and how prices in one area may be related to prices in another area. Obviously, we don't have quality information here, and I would acknowledge that is really important to consider. I would also say that often we talk about prices and then we bring up quality and then throw up our hands and walk away, and it's probably time to stop doing that and actually ask the high-price providers to demonstrate quality premia, and that's what we would do in any other space where we're committing our hard-earned dollars, as David noted earlier. So this is something that it continues to be a challenge. For the places where we have a lot of price variation, we don't have quality measures. All the quality measures live in primary care, cardiology, a few clinical areas, and they often leave us with nothing to say about things like laboratory and pathology services. And so that seems like an important conversation to have. These are static simulations. They just assume we could move patients without any reverberations. And again, this is an important conversation to have. We need to think about what are the effects on innovation, what are the effects on the ability of providers to invest. And I think people will often say, oh, excellent. Does that mean my time is up? that that in fact high prices often cross-subsidize under-reimbursed services, and that is no doubt true and a ridiculous way to run a healthcare system. So we also need to unpack those cross-subsidies, and if there's something that being under-reimbursed, like behavioral health, we should pay for it properly and not overpay for lab services in order to get behavioral health services. Just a note, there's much, much more work to do here and lots to think about, and I would be happy to take questions. Thank you.
Ron?
When looking at the tool, I think Chia did an excellent job with the tool. And then listening to David's presentation in terms of the impact that healthcare costs have on all of us, and the fact that people aren't using the tool, how much is awareness play in all of this? Because you have tools, the payers have tools, Chia has a tool. Is it the complexity? Is it just that people are just not aware? I know I've talked to folks about the Chia tool. No one ever heard of it. They didn't know any tool existed. So the question becomes, have we really done the job necessary to make people aware? The tool is a great tool. I've been through it, right? What do you think is the issue? Is it awareness or is it something else?
I think it's most likely something else, although I know that there was not a vast communication effort on the Chia tool specifically. However, when we look at published research over the last decade around price transparency tools, there have been some quite concerted efforts. And again, some employers are actually using incentives just to get people to use the tool. And so far, none of these have caused a tidal wave. When we talk to patients about what they want, I think there are some obvious barriers. One is, in some cases, I've gone to see my primary care doctor, and she tells me I should get a test and I should walk down the hall. So the timing is just not right for that kind of decision making. And I trust her, and there's this sense that the lab down the hall must be better in some sense for managing my care. I don't think we know that for sure, but I would suggest that some purchases are like that. It's just not the timing. There's no pause point where I go off and then look for an independent provider. I do also think that patients for the bigger things, an elective surgery, something major, they are reluctant to shop on price. And the trust in the referring provider is such that they would much rather accept that referral, which I think leads to a question: could we enable, empower, and ask referring providers to help their patients understand what the price differences are, particularly the out-of-pocket price implications? And that's a set of work that we've been playing around with. Anna Sinaiko in particular is very interested in that, and maybe we'll make some traction on that, empowering referring providers to be part of that. So I don't have a precise answer for you, but I don't think it's just about awareness. Not that people necessarily always are aware, but I don't think that's the rate limiting step.
Is the key including quality measures?
Could be. I think that's another theory that, again, hasn't been tested much, although many of the tools have whatever quality information exists linked to them. It's just that it's missing for so many of the high-priced services. So it's not clear, again, how much that will matter.
I think we also shouldn't underestimate the power of convenience. Walking down the hall.
Yes, for sure.
If it's not convenient in today's very, very busy world,
Absolutely.
people will often pick convenience over cost.
Yes, and
at least in some small measure.
Rationally so, if they're not paying anything different for the laboratory down the hall versus the standalone laboratory center.
So thank you, Meredith. That was great. I want to pick up on two aspects of what you said. The first one is the one that you were discussing with Ron, which is what's going on here. And I suppose rather than saying on average, what does the literature show, which we know it shows relatively little, thanks to your and Anna's work and so on, a different question is, do we have any successes? So are there any successes we can learn from? And my reading of the literature is that the biggest success is the reference pricing stuff in California, which is very, very intensive on the insurer to get involved and refer people and so on. But I don't know whether that reading is correct or whether there are other successes.
Llucky for you, I was prepared to testify on this and never
Okay.
got to. So if
Okay.
you would like the upshot of my testimony, would you like to finish your question or shall
Yeah.
I?
I presume you already know what my second question
I
is.
should by now.
Because you're prepared. The second question is, I'm sort of worried about this, the sort of cross-subsidy issue. And I sort of say, suppose we did a big thing where we pushed on, no one should get paid above the 75th percentile on the lab and radiology and pathology sort of stuff. Is that in fact just being a cross-subsidy in that if you lower those prices, prices will go up somewhere else, so you could expend a lot of effort and not accomplish anything? As to what extent is this really a statement about the cost structure of big institutions is high and they're just sort of getting the revenue to cover a huge cost structure, and that we have to address the big cost structure rather than the individual prices?
Yeah. Well, I'll answer the second question first. I don't. It may be. I think there's a piece of truth to that. I think it's long past time to try to address that issue and try to understand it. Almost surely, if we put a cap on a subset of services, those costs would pop up somewhere else. I think we know enough to know that that's going to be true. And where else? I mean, one of the things I was really interested in is to see where these high prices in acute hospitals seem to pop up, because they signal something about the price elasticity of demand, the cross-price elasticity of demand for those services. And so obviously, because people want to walk down the hall, that's why they're not very price sensitive. So I think it's an important question. I don't know the answer to that. It would certainly not make sense to move forward. And also, I think the things that are being cross-subsidized are often important, and we need to know what they are and understand how to support them, again, in a way that doesn't cause waste or inefficiency in and of itself. Even if we're not saving money, we could still be getting a better mix of services. On your first question, reference pricing is indeed the big success, with one caveat. So reference pricing is when a benefit design requires patients to pay the difference between a benchmark price and the actual negotiated price for the provider they're seeing. And those differences can be big. And when reference pricing is implemented, something like a third of patients shift from high-cost to low-cost providers, and both high-cost and low-cost providers reduce their prices by as much as 15 to 20%. And so that's important. However, we can't use reference pricing for everything, because of complexity. If we had 100 reference prices, that would be a very difficult benefit design for people to navigate. And B, they don't all lend themselves to it. They need a pause point. There need to be big price differences. We need to be able to argue that we have comparable quality across providers. And so where it's been done, it's for colonoscopy and imaging and low-risk joint replacement type surgeries. So I think it's one tool. Narrow networks have the same effect. They're less complicated. They also mush cost and quality in a way that is likely to create more backlash. And so we've seen narrow networks be very effective for small employers, for the most price-sensitive buyers, basically, individual market, small employers. Narrow networks save 15 to 20% as well. So they can be quite effective, and they also cause price competition.
Don?
Thanks, Meredith. Couple quick questions. The table where you show the savings as a percent of total spend, the potential savings.
Yes.
So that's kind of interesting for our forward path. It's pretty concentrated. I mean, if you just worked on office visits alone, you get almost half the benefit. And if you,
Yes.
as I say, lab and path, office visits, PTOT, and radiology, you get 90% of what you ever could get, which would mean that focusing for us on those areas might be productive. That's my first question.
Potentially, yes. And then I think, again, we need to think about, well, what is the it? Is it some kind of price regulation? Is it
Total
an
spend.
incentive? Is it a steering mechanism? And then, of course, we're only looking at outpatient here. Once we get the full picture with inpatient services, we might find very different priorities because, of course, a lot of cost is there. Although it's not entirely predictable that they would give us the biggest bang for the buck.
Well, it's really useful because it really would help us focus, either probably on the inpatient side too. I have other small questions, just behaviorally. If we were to choose the price ceiling approach, is there any research that would say that the ceiling becomes the target for the rest of the distribution, that people just move their prices up to the ceiling? We've signaled the market about what willingness to pay really is or something? Do you understand my question?
I do. The ceiling becomes the floor, yes?
No, it becomes the target. If I'm producing something and you suddenly reveal not just that I'm at the 30th percentile, but that it's okay to be at the 75th.
Yes.
Does that tell me to adjust my prices
Yeah,
to the 75th?
that's what I meant by the ceiling becomes the floor. Yes. I don't think so. It's a concern that's been raised a lot. I'm not aware of research to that effect. I don't know, David, if you know something that I don't.
No, I was just going to say, I can't remember if it was last year or the year before, the Attorney General's report on the pricing of imaging. And one of the things that they emphasize correctly is that they're not even using the same pricing basis. That is, some use 20 different imaging codes, and some use 3 imaging codes, and some use 9.5 imaging codes. And so it would be hard to even put in a cap because they're not even the price is not for the same unit. So the complexity would have to go even beyond that.
How do you know the percentile if you can't do that?
I don't know I don't know how you do it, right? So like, the one who groups it into sort of 4 buckets of imaging and the one who groups it into 40 buckets, you then have to say, well, okay, what price can you charge for the 4 bucket one and what price can you charge for the 40 bucket one? So, I mean, I presume one could work something out, but it's actually even more complicated than it seems.
Yeah, that I don't know. On the outpatient side, these are all CPT code based bills. I don't think CHIA had to do any shenanigans at this point. Probably 10 years ago, you did, but.
Well, they might. It depends on the pricing buckets, right? So they do have a CPT code,
Yeah.
but it may
Yeah, you can negotiate
some of this
prices.
variation may just be that one has a flat line across 14 different categories,
Sure.
whereas the other is sort of high on some and low on the others, and so you find a lot of variation. But it's just because they're pricing different units of things.
I think that's knowable, but.
Yeah.
I mean, all I know is we selected the CPT codes specifically for things that had a high correspondence between kind of a code and a bill, so that it was trying to actually capture the true payments flowing back and forth between the payers and the plans. But there's also other payments that confuse the matter, so it's not 100% clear if we've got it right.
No, I wasn't thinking it was wrong. I was just thinking that if there are 2 services and Plan A prices 1 and 2 differently, and Plan B prices the 2 the same.
Yep.
Each one has a price.
Yes.
So, and they all have a CPT code, so it's correct. And you'll find a lot of variation. That is, price 1's price will be different across the 2 plans, and price 2's price will be different across the 2 plans. But that's not a true reflection of, in some sense, the real differences, because one of them is explicitly averaging across the 2 codes, and the other is not averaging across the 2 codes. So they'll look different, but the average payment may be the same, which is maybe what they're trying to do.
Right.
But you're going to look at it, and it's going to look different. Now, you could say, okay, look, we want each one to be at the lowest, but that's not quite the spirit of what they're trying to do there.
Right. Right.
So it's more just like, how do you deal with the fact that they've got a different strategy around how they're going to pay for it?
Right.
Chris?
At least in the case of physical therapy, isn't this an argument for bundles? In other words, it seems like the study was carried out exclusively looking at pricing and not on volume of utilization, right? So, the classic $150 physical therapy, 10 visits is the same as 20 times $75. So, for office visits, it would be value-based care contracts where we would be focused on measuring outcomes and quality as opposed to fixing prices. Can you comment about I mean, what I think is the folly of fixing price, which is the floor becoming the ceiling?
Right, yeah, I'm not sure the floor becomes the ceiling, and I'm not sure that fixing price is the right strategy.
No, is it a coincidence that we're at 3.1% spend? It would be the one of the ways we could come back on that.
Yeah, that's right. I just artificially deflate Medicaid so we get there, right?
Or the commercial insurers raise their prices.
So I guess going back to the beginning, I would say, again, I think a portfolio of approaches is needed to improve affordability, including bundled payment and other forms of alternative payment mechanisms, and focusing on more global approaches. It certainly gets away from some of the price issues, although notwithstanding the fact that when negotiations are made around global budgets for alternative payment methods, they start with last year's spending, which was based on your fee schedule. So I don't think you ever totally get away from the price. So yes, I think we should focus on bundles where possible. And however, fee-for-service is not going away. I think the data we saw this morning suggests that fee-for-service is, if anything, alive and well. And I actually don't think it's possible to work on a short-term affordability approach without addressing prices in some way, whether it's through encouraging competition based on steering tools and wholesale and retail transparency and antitrust enforcement, or a more regulatory approach. So I think all of these things need to be tried. If we could snap our fingers and go to global budgets, perhaps that would be a better approach. I don't see that happening.
Meredith, can you go back to your comments about reference pricing? And I get what you said, it's not the answer to everything, and you can't
Which doesn't mean we shouldn't
do
do it.
Well, that's what I wanted to ask you. I mean, is that something that we should encourage our insurers to, where it makes sense, for procedures where there's a big price variation and, not making it too complex? I mean, is that something we should focus on here?
Yeah, I think absolutely we should. Yes, and we have those conversations about doing this at places like Harvard, which is a large employer, and it all comes down to where are the places where we have enough volume that it can make a difference. And so I think it requires the ability to have access to data like we have, and we're very fortunate to be in a state where we can do that. But the evidence is very clear that reference pricing is effective not only in helping consumers find the lower cost providers, but also in getting prices to be lower, which spills over into the enrollees in the entire plan. So it's an effective strategy.
And where it's been effective, who's driving it? Is it bigger employers? Is it the insurers? It's bigger employers?
It's big employers. Self-insured. Yes. Yeah, self-insured. So the example that David mentioned is CalPERS, sort of the definition of a big employer. So it's the kind of thing that I'm not sure if the GIC is thinking about this, or other folks that you work with, Rick. Yep.
Great, thank you.
But it's very intensive, right? I mean, what they do is not just say, here's the reference price, but they call up everyone and say, okay, you understand if you go here, you're going to pay a lot more than if you go here.
The implementation varies from place to place, but it requires a price transparency tool, which everyone has. But you're right. So it will require the most successful example, I think, are those places where people have to get prior authorization, which gives a really nice pause. So you have to get your prior authorization, and here we're going to give you the information. Yes, you can have that knee replacement. Here's where you're going to pay nothing. Here's where you're going to pay $635.
And within that, how do they deal with the issues of quality? Because I think that's what's driving all this, right? That people at some point are willing to pay a little bit more because they believe the quality's better. And with your healthcare, you want to make sure you get the best you can, even if it costs you a little bit more. But so how, within that reference pricing, does quality play into it?
I don't know every specific example. In the knee replacement example, they could demonstrate that complication rates did not differ across providers. So that clearly has to be addressed. And for some services, it's more straightforward than for others. Complication rates, patient-reported outcomes. But when it comes to imaging studies, I know there are some quality measures, but it may not be easy to wrap your arms around those. So that's another rate-limiting step. But again, I think the question should be, if that price is, in these cases, $18,000 for the low-price provider, $36,000 for the high-price provider, show me the $18,000 of extra value. That's not an unreasonable question to ask.
So one last question. This may not be a meaningful question, but so you're calculating variation in pricing by imputing prices based on the calculations you're able to do from the CHIA data.
They're not imputed. Those are paid claims.
Well, yeah, but what I'm after is this. Should we be seeking more transparency about the deals that are being cut between payers and providers? It's a different way to look at variation, but...
Well, I guess I'm not totally sure what you mean by that. So the CHIA data are what happens when the contracts hit the adjudication system. They're the actual paid prices. What more would you learn from the contract?
The negotiated prices.
That is the negotiated price.
The paid ones and the negotiated
Yes,
are going to be the same?
Yes.
Thanks.
I just want to add one final observation here. It appears to me another policy strategy that could help market functioning work better is protections on out-of-network billing. Some of the services where you saw the most variation are also the services that we've identified that have the highest rates of out-of-network billing, and where there are protections in place that may reduce that variation to something that's more reasonable.
I didn't want to steal my cousin Amy's thunder. But you did.
David, Meredith, thank you very much. Wonderful presentation. We are going to take a 10-minute break. We'll reconvene at 11:30.
Thank you, Mark.
Good morning.
Well done. You can.
So far, I'm just like, shoot for the governor's bill.
Right,
Shoot for the
yeah,
governor's
exactly,
bill. I'm just gonna like,
exactly.
shoot
Right.
for the governor's bill.
And Medicaid, this is why I bring my briefcase every year. It's like, really, you gonna sit and do some work, right? I don't know. It's like minus and security blanket. I can't go anywhere without it.
They don't go off.
Just push the middle button and you have to.
Yeah, you might not. So let me.
Yeah, just write it on here. I gotta go through this.
Pretty straightforward. It's rick.lord at outlook.com.
Oh, still my
your bios together? How's the photography going? It's going.
And you're gonna get bashed.
No, very. Oh, that's a big driver. Launched. Very good.
Not in any stories.
I'm good. Nice to see you.
But
You know, I left it full time.
right, I just got asked maybe to be on Radio Boston tomorrow to talk about all things healthcare, including that bill, so I better go.
Yeah, I've got a like a. Yes. Yeah. This is the last week all thank you for yeah.
This is a good organization. This panel is
Good to see you. Yeah, it's great.
The commission is.
Yeah, no, it's happy to serve all these years, so it's great. So, all right,
Good to see you.
Okay. Retirement is great.
He always does. Oh my God, that's I know. It's really good. I was running
What's the matter with you? He's going to retire at such a young age.
By all means, call my wife. She's going to
How'd it feel?
I'll give her your card.
He's like a lonely person in here. And he like has fixed things. He's like had a bet.
Yeah. Tell me about it. Yes.
I just want to
Yeah, that's good. Yeah, we got to keep that. Your practitioners look established. They can do it now. Oh, yes, keep it in the bill. Yeah.
And the other one that they did was the psychiatric facilities nurses could admit and certify restraints. They took it just like I sent her an email. So there'll be intense lobbying. Oh yeah, we got a long way to go.
Yeah. Although I think, in terms of the nurse practitioners, I think we've run down.
I wanted to ask you why.
That's key, right? Yeah, I think we've run down. They have been able to stymie it pretty successfully thus far. Like 15 years. Yeah, but it's, I think they don't want to say they've reached the point of surrender, but they know we've surrounded them.
Yeah, I'm going to know all the businesses supported all of the scope of factors. That makes sense.
Makes sense.
Yeah, right.
But I know that Ron Mariano, the leader, has had a big influence on all of this. Right. I think on nurse anesthetists, podiatrists, he's adamant to not expand, do not let the lesser professions into that because of the risks inherent in it. I think he would say dental hygienists and nurse practitioners. It's okay.
I got to go see him about the nurse psychiatric.
And actually, what will probably happen, the outcome will probably be referred down here to HPC for your sign off on it. Yeah, so it'll say, nurse practitioner, blah, 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 authorized, subject to review and approval or some kind of thing.
They already wrote a report that said that you guys did that.
yeah.
You probably wrote that section.
Which is why we have no objection to that. Send it to the
right.
HBC.
Yeah.
They're the disinterested professionals.
It's amazing how many additional responsibilities the HPC has been handed over the last few years.
Hot potato,
Yeah,
here it goes.
I know it. So how'd it feel to get back in the flow? Put a tie on, deal with the traffic this morning?
What did you do for the summer? Because you were, when did your effect?
Yeah, and actually John has taken over it.
Back in May.
So you had a
nice summer.
Nice summer. That's great. Good for you. Good for you.
Well, he's got a nice. You should tell him he's got a few things he's still got a hand in. So he's keeping busy enough.
Abe created an insurance company 30
Yes,
years ago.
sure.
Abe Mutual. So I'm serving on that board.
Good for you.
Sharing their message.
Good. Oh, okay.
Yeah, he's got a
bunch of nonprofits.
How's Sissy doing?
Sissy's doing fine.
She's retired too.
Yes, she is. Jimmy, how are you?
How you doing? You're a professor, right?
Well, I was spending some time over there, and I signed on with Rasky, so we'll be seeing you a little
Oh,
bit more.
excellent.
So.
Oh, you did?
I agree with you. That didn't feel like I wanted to go into a big organization.
So you got a lot there, or just whatever?
Yes, I'm already on the compliance. Oh, very nice to see you. Came a long way to be here. Yeah.
Oh, yeah, say hi for me. Great, yeah. How's it all going out there? The CCO still?
From time to time, I'll add on to some of the process.
Wow.
Yeah, nice to see you too.
Which one did they buy?
That would be great. All right. Okay, thanks.
I get the newsletters.
Did Katie volunteer you for
try to
the
keep
panel?
ahead of my friends.
That's so nice of you.
No, absolutely. And it's funny, Gerald kept saying, like, everybody's thanking you for doing this. It's like,
Oh,
oh my gosh.
Christina. Oh, okay. Oh, really? Health Catalyst? Community Catalyst?
Community Catalyst.
They've only been here
Like this.
You've been hanging around.
Yeah. Yeah, I'll watch you. Yeah.
So you're me at the train.
How are you?
How are you doing?
Nice to meet you.
I'll catch up.
You're doing a great job.
Thank you so much. He had strep throat in the previous cycle.
Hey, how
You
you
know,
doing?
pediatrician's wife meds and off you go, buddy.
No, the reason I was trying to call you yesterday is because
Yeah, I think the staff is onto it now.
But I'm also fine if you guys want to.
No. She thought that you were one of the storytellers. That was the confusion because I didn't identify you to you because I was writing to you.
Totally fine. I'm happy to do whatever you guys need me to do and happy to not laugh. Yeah, like just whatever people want is good. Okay.
We'll talk about it.
Okay. Sounds good. That sounds good. It's on my calendar.
Well, this is the hearing. I'm going to put this
Hi.
Good, great.
Yes.
I never had like a break. Anytime.
I've been hitting it.
Yeah, what do you mean? That's hard to understand because the way I know it's accurate is I get it from your system.
All my former students are always here at the cost trends hearings. It's very fun.
Oh.
Hi, Cheryl. How are you? Good morning. Alejandro Esparza. Nice to meet you. Yes. Western
All right, we're going to get started. If everyone could please retake your seats.
Do it by email, please. So just send me an email to me, to Don Gerwig.
The one with the lower price cost.
The one with all what?
The lower price cost.
The lower price cost.
What are we doing now?
Yeah, I don't actually understand what you're doing.
Hey, how are you? Good, how are you? Good to see you. Oh, you're welcome.
I can't. Yeah. If Brandon wants to call me and orient me, that's fine. Thanks, I gotta go.
All right, well, thank you, and welcome back. With that great data and research foundation, we're going to start diving into our 4 witness panels. These witness panels provide a great opportunity for the HPC board to engage with witnesses from across all of the different important stakeholders in the healthcare system here in Massachusetts. Our first focus area of the day, and for our cost trends hearings, is confronting complexity in the healthcare system. I'm going to just provide a quick overview of this topic and some of the HPC's work in this area before turning to our witness panel. At last year's cost trends hearings, Ashish Jha gave a compelling presentation about administrative complexity inherent in the US healthcare system that adds costs and sets us apart from most other developed countries. We at the HPC use this as a springboard to launch a broader examination into administrative complexity in Massachusetts. We've been reviewing the academic literature on administrative complexity and building estimates of the cost of that complexity in Massachusetts, which you'll see in a few slides, and talking with many of you in the room about priority areas for action. Administrative complexity can take many forms. Some of this complexity may have benefits, but much of it may not. While the cost of administrative complexity is a major concern for the HPC, there are other negative consequences, including confusion and anxiety for patients, provider burnout, and organizational distraction from other priority areas. It takes resources to manage all this complexity, and of course, different payers, providers, and consumers have different access to those resources. To provide further context on this discussion, we began by quantifying payer and provider spending on administrative expenses. There are some, excuse me. There are some big numbers here on this slide. But we want to emphasize that some level of administrative spending is necessary and beneficial, and that these numbers do not necessarily represent total waste in the system. However, what we find when academic research looks at administrative spending, they typically look at billing and insurance-related activities. And insurance researchers generally categorize all health plan spending as billing and insurance-related, because basically everything health plans do is inherently insurance-related. For providers, billing and insurance-related activities are those activities required to interact with health plans. Everything from provider enrollment to billing and claims to prior authorization, dealing with formularies, reporting on quality measures, et cetera. Nationally, researchers estimate that billing and insurance-related activities accounts for almost $500 billion annually, which is approximately 13 to 14% of national healthcare spending. And a large share of the spending is actually on the provider side, with hospitals, physicians, and others spending over $280 billion a year on billing and insurance-related activities. If we include all administrative expenses, including those not just related to billing and insurance, researchers estimate up to 30% of healthcare spending is for administration. And when we apply those figures to the Massachusetts experience, we find that in Massachusetts, approximately $600 to $840 million a year is being spent by physicians, another $800 million for hospitals, for a total of approximately $1.5 billion annually for providers to interact with commercial plans. And these estimates are likely conservative as they do not take into account other parts of this healthcare system beyond physician practices or hospitals, or interacting with other health plan types. In Massachusetts, private health insurance companies, the net cost of private health insurance companies was $2.5 billion in 2017. This is that retention that Ray was talking about earlier. And as Ray said, that number actually increased to $2.7 billion in Massachusetts in 2018. And this includes everything from taxes and fees to broker fees to general administration and, of course, to profit and surplus. So we asked payers and providers what are their priorities for reducing administrative complexity. And we surveyed the HPC's Advisory Council, and we also surveyed over 40 organizations through our pre-file testimony, and we asked them what are their top areas for priority in reducing administrative complexity. The providers identified billing and claims processing, prior authorization as their top priorities. The health plans identified EHR interoperability, provider credentialing, and provider directory management as their top priorities. Unfortunately, but perhaps not surprisingly, there was little overlap between health plans and provider priority areas. We at the HPC have thought about many ways to potentially address administrative complexity, and we've bucketed those three strategies as shown on this slide. Reducing variation and duplication, such as by reducing unnecessary repetition with processes or by standardizing requirements. Leveraging technology, meaning reducing fax or written documents, using technology to be able to get efficiencies or be able to incorporate things into the workflow. And then finally, potentially even eliminating low-value tasks. I'm pleased now to turn it over to our witness panel to talk about this in an even broader sense, because this isn't just about complexity that impacts providers and health plans. This is complexity that impacts every single part of the healthcare system and everyone who interacts with the healthcare system. So we're pleased to have a wide representation on this panel. And with this, I'm going to turn it over to Dr. Berwick, who is going to help lead this particular panel.
Thanks, David, and thank you for all being here. David's introduction needs a little supplementation. It is true that the research literature on waste in the healthcare system almost always settles on this rather vague and large category of administrative waste as the number one, the largest component of waste. Will Schrank's recent article in JAMA is just the most recent shot, and he estimates overall waste in the system at 25% of the total spend in this country, and the biggest chunk of that is this administrative category. So the staff and the commission have been trying to dig deeper into the granularity here, understanding what it is, and you're going to help us today understand what this category really looks like. So I'm not going to introduce you individually. I'll ask you to do that as you start to speak, so we won't take the time. And so we'll begin with you, Dr. Apkin.
Good morning, Madam Secretary, Commissioners. Thank you for inviting me to be part of these important conversations. My name is Michael Apkon, and I'm here as a physician executive leading Tufts Medical Center and the Floating Hospital for Children, and also as an employer of over 5,000 people, and as a physician who's cared for some of the most medically complex people in our population. I come to my role at Tufts Medical Center after spending the last 20 years working to enhance systems of care in order to advance access, safety, and the quality of care. I also returned to Massachusetts. I'm a Massachusetts native. I come back with a relatively unique experience of having worked across a number of different healthcare systems around the world, including leading one of the world's top children's hospitals in Canada. During my 5 years in Canada, working closely with the Ontario government on health system policy, I came to appreciate their healthcare system as an example of a system with universal coverage and outstanding outcomes, while at the same time having a far lower burden on providers and, even more importantly, patients and their families in terms of the cost and complexity compared to what I've become accustomed to here in the US. My appreciation of the Canadian healthcare system notwithstanding, I've been inspired by the level of innovation here, spurred by our market dynamics. And in fact, the innovativeness of our market was one of the draws to me coming back to New England. However, I also developed a healthy respect for the unintended consequences that our Commonwealth and our country bears in terms of the cost of care, limitations to access, and maybe most importantly, the compromises to the health of the population. My views are informed not only as a healthcare provider, but also as a large self-insured employer. We're doing everything we can to help our workforce stay healthy, and we're still facing nearly 10% annual increases in our own healthcare costs. I saw the numbers presented earlier. I wish that we were seeing the level of inflation presented in those slides. And this is a trend that unfortunately will continue. And I'm growing increasingly concerned about the cost of insurance for our employees and recognizing that insurance doesn't cover the full cost of care, the financial impact on those employees who fall ill. As I have an opportunity to take a fresh look at our healthcare system, I'm struck by a number of challenges that appear to impede value, compromise access, and needlessly raise costs, while at the same time burdening people seeking care as well as the people delivering care. And we talk about administrative complexity to give you one sense of the difference that I've experienced for a similarly sized hospital in terms of both budget, admissions, and bed number. In Canada, we spent $1.4 million at the hospital to manage the entire revenue cycle operations, registering, pre-authorizing, collecting bills. At our hospital today, we're spending more than $50 million for that same activity. 50. The challenges that we see include the administrative complexity, the misalignment of incentives to address the needs of people over time, failures of markets to address healthcare disparity or to balance the benefits and against the adverse impacts of scale, both at the insurance and the provider level. As we contemplate a path forward, I recognize that the forces in place to maintain the status quo are really strong, and we have a local and national economy that are vested in preserving the current system in many ways. At the same time, I also believe we need to define a direction that will better ensure universal access, reduce complexity, eliminate the disparities that we see, and use resources more responsibly, as well as to put more of the healthcare dollar into healthcare delivery and less into the administrative costs. Thank you.
Thank you very much, Dr. Apkin. Rather than have questions before you're done, I think we'll run the panel and then open it up to questions for everyone. So, Ms. Corman.
Thank you for having me this morning. I am the Executive Vice President and Chief Human Resource Officer at Middlesex Savings Bank. We are a $5 billion independent savings bank with no stockholders. And we are basically in business for the mission of serving our depositors in our communities. And in our communities also include our employees, who are critical to our success. We currently have 575 employees, and with over 30 locations following the 495 corridor and the Metro West region. We also have, I currently also serve as a trustee for the Group Insurance Trust through the Massachusetts Bankers Association. We purchase our insurance as part of a larger group, which allows us to gain the benefits of economies of scale and allows us to be able to have some protection from risk associated with high claims utilization. So my role at the Group Insurance Trust as a trustee allows me to understand not only the size of population and the challenges that I see from my own organization, but also for over 100 banks. Those banks range from anywhere from 50 employees up to 1,800 employees. And so it allows me to understand some of the disparities of some of our institutions. When I look at the smaller institutions, the challenges that they face in trying to provide health care that is meaningful for their employees. If they didn't have the association, it would be much, much more difficult for them. When we look at and larger organizations such as mine, I'm very fortunate in that we are able to take advantage, or we're beginning to take advantage of a lot of the technology that is becoming apparent in the market, and things that we're actually working towards to try to reduce the complexities associated with healthcare itself. When we look at, as an employer, it is very challenging to find individuals who are understanding of the complexities of healthcare and being able to explain them to our employees. So the labor market, many people don't have the years of experience in order to be able to provide a liaison for our employees and to be able to help guide them appropriately. When we look at other opportunities that I participated in, I've also been a member of the Health Policy Cost and Quality Council at the Associated Industries of Massachusetts. It has provided me 10 years worth of education, thank you, Rick, for education of relating to healthcare issues, not only for the purposes of bringing things back to my employees in regards to knowledge and education and the things that they need to try to make their lives easier, but also it allowed me to understand the larger picture of what was happening within the state and what was really the differences that we had and the fortunate items that we're able to gain for our employees versus what other employers are doing. And lastly, I've had an opportunity to work on a patient family advisory council. I was a co-chair for 3 years, and a member for 5 years for a community hospital. And that also allowed me another perspective of understanding the service and the quality that our hospitals are trying to deliver to their patients and some of the struggles that they had seen. It allowed me an opportunity to work with members of the hospital, but also with members of the community who were really advocating for changes within the hospital delivery system. And when we talk about readmissions, the opportunity to be able to understand why readmissions were occurring within that particular hospital was some of the data that we used to try to be able to promote changes in their care. So overall, I've taken an opportunity in the past 10 years to educate myself, but also for the purposes of the greater good for our communities at large, but also for our employees. We look forward to continuing to grow in the Commonwealth and the ability to be able to provide better services and connections to our providers as we continue to grow. I will tell you, looking at it from an employer perspective, it is extremely costly. Even though our increase this year was not in a double digit, we were fortunate. We actually had a composite increase of 4.4%. It still will cost us over $300,000 to be able to provide the existing level of co-share that we are providing for our employees. And even at that level, I will tell you that at an 80% that we're absorbing the cost of that premium, it still is unsustainable for our employees. And we employ people who are entry level, who want to build a career, who really want to make a difference in the financial services industry, and you have the values that reflect our culture. And when we look at that, we also move directly up to our C-suite. So we have a variety of individuals who are impacted, some that can afford it more than others, but all, even in the C-suite, are confused by our healthcare system. So I thank you again for the opportunity to be here today, and I will move on to Alejandro.
Thank you, Ms. Corman. Dr. Esparza-Perez?
Yes, good morning, everyone. Thank you to the Health Policy Commission for inviting me today. My name is Alejandro Esparza. I am the Chief Medical Officer at Holyoke Health Center, where I've also had the privilege of being a primary care provider for the past 17 years. Holyoke Health Center is a non-for-profit, federally qualified community health center with locations in the cities of Holyoke and Chicopee, Massachusetts. We have been providing care to across Western Mass for now close to 50 years. The services that we provide to our patients are medical, dental, pharmacy, oral health, substance abuse, and behavioral health integration, among others. Our mission, which is something we're very proud of, is to basically, in essence, provide the highest quality of care at the lowest cost for the underserved communities that we serve. And so that gives me a very good perspective, given my professional experience as well as my current role as a physician leader in an organization, in being able to address some of this very important and timely topic that we're discussing today about the administrative burdens and also issues around provider burnout, et cetera. We have served over 22,000 patients over the last year. We currently have around 330 employees in our health center. Thank you again for inviting me today.
Thank you very much. Amy?
Hi, good morning. Thank you for having me. My name is Amy Rosenthal. I'm the Executive Director of Healthcare for All. As we approach the year 2020, we're celebrating our 35th anniversary of Healthcare for All. And for those of you who aren't familiar with us, we advocate for health justice in Massachusetts by working to promote health equity and ensure coverage and access for all. What really drives our work is our helpline. We take 20,000 calls a year in 3 different languages. We're proud of the fact that we enroll about 2,500 people every year. But if you look at the number of people that we enroll versus the number of calls that we take on our helpline, you'll notice that there's a big gap, which means that the purpose of our helpline is not just to be enrolling people. It's to help people navigate very difficult, confusing situations in their healthcare that they simply don't understand. And this really spans people from all different types of backgrounds, all different types of coverage options. And while we certainly focus on the most vulnerable, we know that this is a problem for people across the board. There's a couple of just key takeaways from what we've heard on the helpline that I just want to quickly share. So number one, administrative complexity is a problem that consumers are experiencing firsthand at multiple stages of the process, and often at a time where they're most vulnerable. We've identified 4 parts of the process, which I'm happy to share with you later, as to where we think those problems are happening the most. Number 2 is that consumer education is not the sole answer. I think we heard from Meredith that consumer-centered education can't change the marketplace. And I think that the system is extremely confusing, as we just heard from Cheryl as well, not just for people who are vulnerable, but also even for our own people on our staff. Talking to our 3 most sophisticated policy experts on our team, they all identify the fact that they too have had trouble navigating the system. And for our public health friends, I would like to actually draw an analogy. If you look back in 1923, the first year we started collecting data on fatalities related to car crashes, we were at 18.65% deaths per 100 million miles driven. In 2017, we've seen a 93% decrease to 1.25% deaths. It's not because we've become inherently better drivers. It's because we've actually adjusted our cars to make them safer for all of us to be driving. We didn't just put the onus on the driver to make the roads safer. I would argue that's a pretty good analogy for us here, which is that yes, we have to do more to make us educated and make consumers make smart choices, but at the end of the day, the system itself needs to inherently be changed in order to try to bring reduce complexity and stress to consumers. The third point I'd make is that as we work on this and as we see results, which I'm confident that if anyone can do it, it's Massachusetts, those savings have to be passed along to the consumer. So I do appreciate the fact when I get up here that the data has already been presented from the incredible chart pack from Chia, as well as the last presentation, that even though we've seen the cost bench growth mark hit where it needs to be at 3.1%, that is absolutely not translating for consumers, and they are bearing the brunt of that in their out-of-pocket costs and their premiums. And the last thing I will say is that consumers do need support while we're trying to figure out how to fix this. I was just at a conference with other leading states across the country, Maryland, New York, California. Our state does invest significantly less money in our navigation support and consumer assistance support than other states. And I think that as Meredith talked about the warm person at the other end of the phone, as we're solving this problem and need to make sure that we're doing everything we can for consumers, in the meantime, the short-term solution is making sure that those resources are out there and we're not just putting the consumer out there by themselves to figure this out. Thank you.
Thank you so much. And Mr. Siegel, thank you.
Morning still, everyone.
Could you Could you put the mic closer to you? Thank you.
I'm David Siegel. I'm president of Always Health Partners, which is part of the Partners Healthcare System. Thank you for having me here today. At Always and at Partners, we see that there is a clear opportunity for a lot of collaboration, a lot of innovation around reducing administrative complexity. And we see that opportunity going beyond just our partners' relationship to other parts of the network as well. So it's not an exclusive thing to partners. We're trying and have created some simplified access to quality care by removing a lot of barriers, leveraging partners as a differentiator, using them to be a tool for patients to get access to high quality care through Partners Healthcare on Demand, a virtual program. And doing that in a way that we hope will scale to the market over time and accrue benefits both in terms of access and cost. We have done a lot to remove barriers, and we know we need to do more, especially as it relates to chronic disease management, evidence-based interventions, an emphasis on prevention and adherence. We work very hard to increase our provider engagement, and we've made some very specific things that go beyond the partners' world itself to make life a lot easier for our provider partners working to provide care to patients. We try to be customer-centric whenever and wherever possible, and our product designs try to reflect that. Thank you.
Well, thank you all for your introductory remarks and for your time here. We couldn't ask for a better panel. We're covering really right across the system, different voices. So the data are really clear that whatever this pot is, administrative cost, complexity, is large. It does not appear to add much value, if any, and it does appear to add some burden and angst to the system. If we're looking for low-hanging fruit, this ought to be the lowest fruit on the tree. So we're really interested in ways to change. I'll kick off with the first question and then open it to my colleagues to really go into this with you. So I'm going to ask one question for all of you, just to kick it off. I'm going to give you a magic wand and say that you could change one thing that would really improve the experience of whoever you represent, providers and employees, clinicians, patients, plans. What's one aspect of the way we're running the show that you would like to change to reduce the negative impact on your organization or on your constituents that this complexity has? So you get to make a change.
I think a lot of the administrative complexity arises from the bespoke nature of the relationships between employers, insurers, and providers. And if there was one thing that would cut that significantly, it would be a single fee schedule of some sort with a single standardized rule for how to adjudicate the claims across the system.
Mike, could you just dig one level deeper? So what's it like for you to try to manage the complex fee schedule right now? Give us insight on what it feels like.
We manage a number of different fee schedules within each insurance company. We have multiple fee schedules, multiple different benefit packages that have different approaches to pre-authorization. And we have built a system that has to manage that complexity from the very beginning of negotiating those fee schedules through coding them into our electronic systems, through managing the processes of registering, pre-authorizing patients, collecting the fees. And I think because of the nature of the differences in fee schedules across the entire structure of the system, there is it creates complexity for patients that are trying to figure out where they can go. Because everybody has a bespoke solution, not every provider is participating with every plan. And as patients try to navigate the system, they are trying to navigate through a series of providers, some of which may be providing coverage, some of which don't. That leads to the difficulty of surprise billing. It's one of the consequences that we see there. It also leads to a discoordination of care where we have, for example, within our WellForce healthcare system, where we have two very capable community hospital partners, we have situations where their patients are covered by one insurer that we don't have a contract with, and that means having to move patients from within our network to beyond our network and manage the complexity of that, as well as the complexity of figuring out how to drive a clinically integrated solution for patients and for the referring providers in the face of that kind of a system. A single fee schedule, much like Medicare, makes it almost impossible. It reduces the reasons why people wouldn't participate, and would create a much more universal engagement across the system between employers, payers, and providers.
Thank you. Ms. Corman, your magic wand.
My magic wand. My magic wand would include simplicity, and since that probably will not happen anytime soon, then I would say that I know that we've talked about the use of technology, but being able to leverage a system that is integrated, that would allow our people to understand that when if they use their phone or they use an app, what they would be able to do is understand exactly what is the impact to them, as well as, and in particular, the cost associated with that. I think that most people want to do the right thing. I think that many times they're not aware of what the right thing is. And in the moment when they are facing critical health choices, then for them, they're just really emotional. They are just trying to care for their family members or for themselves. And then they'll figure out the cost later. So I think for them to have a just-in-time system that would allow them to understand exactly what the impact is within whatever healthcare system that we have, it would allow them to be better consumers and disrupt them right there and then in the moment and allow them to understand those consequences.
Thank you very much. Dr. Esparza?
Well, I guess my wish would be one, to decrease variability, although this will probably have a lot of impact throughout pretty much everything that we're going to discuss today. One of the things that it's a big pain point for us, even though maybe a little not as intuitive as you might think, even since I represent most of the providers and patients, but the credentialing aspect of things and the variability associated with credentialing is something that hinders access. And if we are to succeed in the world of value, it is extremely important that we are able to be nimble around creating access to our patients, not just to our existing patients, but also to new patients. We are currently part of the first primary care-driven Medicaid ACO in the state, Community Care Cooperative, and we're under tremendous pressure to be able to create access. And having such variability among payers, hospitals, and other entities around the credentialing system, it's extremely burdensome for us. We're talking about the experience of the provider around having to manage and deal with the sheer amount of paperwork that needs to be created around this process, and also the different requirements that each payer has. I can give you a couple of good examples. Just recently, we've actually launched our first family nurse practitioner residency program to try to increase access for our patients. And we had our first cohort. One of those nurse practitioners actually came from Virginia. And just the process of having her license reciprocated in the state, for me, it was counterintuitive that it would take a lot longer for her to be credentialed in the state than somebody who's actually recently out of training. So that's one specific example. Other things that I think it's very difficult for us is to manage around the process. In a good day, when we have the unfortunate news that a provider will resign, it takes 6 to 12 months to be able to recruit somebody to come to us. And then if we're factoring in the issue about the credentialing, we're talking on a good day, 3 to 4 months, or at worst, 6 to more months. So we're delaying care for over a year and a half for thousands of patients who need access and who probably are accessing care at fragmented places like urgent cares or emergency rooms. And that's increasing the total cost of care. So I think dealing with that, it would probably be the easiest lift, as opposed to managing complexities around electronic health records, health information exchanges, and things like that are extremely complex to deal with.
Credentialing here does it include licensure, professional licensure, membership on hospital staffs, provider, payer credentialing, all of the above?
All of the above. Yeah, I mean, usually the easiest, process for us is, collaborating with our local hospitals. We usually have a better, but when we're trying to credential people with the payers, it's more about this is a process that doesn't occur in concert, it's more occur in tandem. So you need to complete A, B, and C before you go to D, and that really delays the process.
Amy?
Well, I certainly would want whatever we tackled first to make sure it had direct benefits to consumers. And I do pride myself on trying to be a somewhat pragmatic progressive. So I would pick addressing out-of-network costs and surprise billing as probably the first thing, because I do think it's achievable. I think it's manageable. I know it was in the governor's proposal, as well as I know both chambers have been doing a lot to talk about that issue. I think consumers would see a direct result, and so I would say we should get that done this year.
Ms. Rosenthal, what about pre-authorization? I thought you would speak to that.
So I'm happy to talk about pre-authorization.
I'm giving you two magic wands.
So we appreciate what prior authorization has tried to achieve, and we again don't ever want to say that we don't think influencing consumers should not be part of an overall solution. With that being said, it's extraordinarily complicated, and oftentimes consumers end up having to wait for care. I will just say I am the head of Healthcare for All. I have a pediatrician husband who works in a healthcare system where my daughter gets her pediatric care. It took 12 phone calls and 3 weeks to get prior authorization on some care she needed last week. And so it is extremely complicated and extremely difficult for consumers to navigate. So yeah, if I get two, we can talk about that as well.
Thank you. David?
How many do I get?
You're a payer, one.
Thank you, Mary Lou. I know where this is going to go soon. So I'm going to tell you the three I had, and I'll talk about only one. And I'm doing the magic wand thing, but it was patient navigation, ease of patient navigation, interoperability, and codes themselves. And I'm going to pick codes. Because if I were to wave the magic wand and think about how do consumers get educated about their choices, we're trying to take inside baseball stuff, CPT-4 codes, ICD-9 codes, and translate them into something that an average human being can understand and say, make choices based on this. That may all work for us in inside baseball, but for the consumer, it's just, I don't see how it's actually possible to overcome that in the current paradigm. So my wish is that we either using, again, this is a long ball magic wand thing, either we do some changes to the way we do coding, or we leverage artificial intelligence in ways that haven't been tapped yet to make it into something that is far more consumer friendly and actually would enable ease of understanding what they're buying under what circumstances.
Why does the consumer need to know anything about the coding system?
They don't, that's the point. But when they're making choices about do I go here or go there, is this a high quality or a low quality? If I think this is the cost that I'm going to incur, are there any surprises at the end of that? But if you don't have all the codes laid out, that's what you thought it was, and then there are 5 other codes over here that no one ever told you about.
Got it.
Could I make one point regarding the patient, the billing codes? So I just wanted to share a story that one of our employees had shared with me. And basically, he had shared that his son was going to school in New York and had needed to go to an urgent care facility. And so he went to the urgent care facility. The individual had a PPO plan. It should have been covered, no problem. However, unfortunately, this individual got a bill in the mail. And it was a significantly large bill saying that it wasn't covered. However, when the individual called the health plan indicated that it must have been billed incorrectly and that the center had used the wrong code. So the individual took the time to go ahead and call the center where his son was and talk to them about the billing and the code. and they pointed back to the healthcare, back on the other side of the healthcare provider. So after about a half a dozen phone calls and this individual's time, and let me tell you, this is a senior leader on our team, and it costs a significant amount of money for this man to be making these phone calls back and forth. And then we got involved on my team. And then we got other people involved. And so approximately 3 months later, he finally did not get a bill. Yeah. And it took that long for people to get that billing changed. So, so in regards to that, I feel some pain points, especially on behalf of some of the people in, at my organization. So.
I would just point us back to David Arbach's slides that talked about the fact that the people who are seeing the increased costs, 50% of them are single parents, 32% of them are already experiencing worse health conditions, 30% of them are non-white. So the ability of them to make those phone calls, and I'm not saying anything that wasn't hard, but there is an additional burden for people who are most impacted by this to have the time, to have a job that allows the flexibility for them to be on the phone during the workday. I could go on, but I think I've made my point.
I just want to add something around coding and how coding affects an organization like ours. So obviously we find ourselves in a situation in which we need to prove the value of the care that we provide by being extremely, I guess, diligent around coding. Our providers find themselves having to code specific things. For example, a double amputee will need to be coded once a year, even though it's a condition that will never change. So this is something like some low or low value things that do not add anything to the patient care and frustrate providers. So just a small example of many like that. But coding, obviously, this is a different perspective on how it affects us.
What did coding look like in Canada, Michael?
So there was a similar issue with coding in Canada. The payment, it varied by province, but in Ontario, which is where my experience was, the system was moving from global budgeting of hospitals, where you just got a lump sum and you cared for whoever came through the door, to a system that looked much more like our DRG system here. And because the hospital budget was distributed based on acuity adjusted activity, there was a renewed interest in being able to demonstrate the value of the care that was delivered. And so a very similar path was taken by hospitals there, investments in electronic health records, which helped address coding, investments in clinical documentation management activities to try to ensure that we were properly documenting. But the level of complexity that was required to do that, in part, there's a single payer, single fee schedule, a fewer number of things that had to be documented to be able to justify the level of acuity. So there's a lot less cost of that activity, but the nature of that activity was similar. And hospitals there, as hospitals here, justify their investments in things like electronic health records in part by the additional revenue that they believe they'll be able to bring in as coding improves. And I think a skeptical view or a cynical view might be to look at that as gaming the system, and there's a lot of discussion about that in Ontario as there is here. I think it's, as a provider, I would say it's responsible management of the business. I think every business needs to ensure that they're able to garner the resources that it takes to do what they do. And that because our system depends on demonstrating the acuity of the care and the complexity of the care that's delivered, we make the necessary investments to be able to do that, and it allows us to continue to perpetuate the mission.
Thanks. All right, well, please, David.
Actually, can I just follow up on this for a second? So as Dr. Apkin, you noted, you don't have to have that degree of coding detail. So we could just say an office visit is an office visit and there's one price for it. And an ED visit is an ED visit and there's one price, except in a very, very few set of circumstances where it might be astronomically more costly or so on. So I guess I want to ask everyone, is this an area that we should push towards, that is dramatically simplifying the number of things that are billed for, trying to push to dramatically simplify the number of things that are billed for?
Well, and I guess the devil will be in the details in an organization like ours, in which community health center, which we carry a large population who is underserved, and we have to address a lot of social determinants of health. An office visit is not an office visit for a private setting or a place like ours. So I think it will be difficult to be able to reflect, the complexity that we provide, or the care, or the complexity we provide to our patients if one size fits all. So that would be.
We do need to recognize that different resources go into different levels of care. The larger the scale of the activities that you're aggregating, the easier it is to average across and not compromise one provider or another based on the type of patients that they are caring for or the types of services that they're delivering. When we're managing this at the scale of a hospital or a physician's office, I think it becomes increasingly important to somehow differentiate around the resource intensity of the care. And it's been interesting watching other countries kind of go back and forth and watch the pendulum swing between very average approaches, global budgeting, or a very simple fee schedule, to trying to promote greater access to more complicated services by creating greater differentiation across the service portfolio. And while I was in Canada, we were seeing this move over the 5 years that I was there from a path that was more global budgeting towards a very much broader, discrete level of adjustments to something that now is starting to swing back towards taking accountability for larger populations. The change in the system that allowed that pendulum to come back more towards the center was aggregation and integration across many different providers, so you could start looking at taking risk or managing the variation in the cost of delivering service and the care that you were asked to deliver across a bigger population and a broader range of services. It also created more flexibility in figuring out how to package the services to be able to manage the cost and utilization in different ways. Without that, at least in that environment, I think here also it becomes important to be able to differentiate the payment for services based on the resource intensity.
Did that not raise prices because of market concentration effects?
Well, so in Canada, because there's a single payer and the government decides how much the budget for healthcare is going to be, it did not raise prices. And in fact, for 5 years, the government of Ontario held the hospital operating budget envelope across all hospitals completely flat and distributed it based on a pie sharing model that was based on acuity adjusted patient activity, so that the money followed the patients. There is a negotiating relationship between the providers and the single payer there, government, and there was an annual negotiation to a certain extent, but it was really around the size of the envelope and to a certain extent the rules of distribution, and the competition was really created by the fact that whether it was a fee for service or a pie sharing type of approach, hospitals were competing for market share, and they were competing on the basis of the quality of the service, the access that they could provide, the convenience, and things like that. They were facing a level playing field from the standpoint of the profits that they were able to generate or the surplus they were able to generate as a result of their activity.
Thank you. Other questions for our panel?
Yes.
Yeah.
Did you want?
Yeah,
I'm sorry.
I just want to add, when we went from ICD 9 to ICD 10, it still puzzles me what the intrinsic incremental value is for that transition. I remember looking at codes that said squirrel bite, left arm, first time. I swear to God, that was a code.
Pushed for that one.
That was a code.
Was there for a second time?
And so I think what we want to do, I think we need to define the objectives and figure out how do we solve each objective and what's the path to get there. The issue I was raising is if we're trying to have more informed consumers, then they need to have a sense of, I understand what this market is all about, and having codes or buckets of services that make sense, that they can understand what they're purchasing is what matters. To Dr. Abcon's point, if there are things that you need to understand acuity, that's a different use. So you know, maybe this is an artificial intelligence play given technology that we have available to us. But I wouldn't say let's run down one path versus another until we're really clear about the objectives of what we're trying to do.
Thanks. Chris?
Yeah, not to stay in Canada, but it is a kind of a unique perspective. Can you, in your opening, Dr. Apkon, you used the word innovation that sounded like you're able to accomplish that more readily here than in Canada. So can you talk a little bit about what sounds like some administrative simplicity in Canada against the trade-off?
Sure. The way I've come to think about innovation is that this marketplace is very good at what I might refer to as micro-innovation. You know, it's easy to build a startup company, to test some concept, and if it makes sense in the market, it'll eventually take root and grow. It's harder to innovate at a very large scale level around, for example, you know, payment reform or the structure of the system. In Canada, that's more or less flipped. Because the government's the sole purchaser, there's a market for the supplies that go into healthcare delivery, and there's a market for labor. And so you can innovate kind of at the fringe in that way, but it's harder to innovate at a macro, the macro innovation, though, is somewhat easier. If government decides to take up a new innovation and deploy it, it happens with the stroke of a pen. So Governor Baker was talking about legalizing telemedicine, although it's been invented here, but we still haven't really deployed it in a wholesale way. In Ontario, telemedicine is widely used. It has been for a number of years. We were doing several thousand telepsychiatry visits a year across the entire province. We were doing specialty med-surg visits across a very distributed geography. It's supported by a single telemedicine connector that is province-wide. In terms of patient navigation and patient portal, the government of Ontario, and in fact virtually all the provinces are moving in this direction now, if they're not there already, are moving to single patient portals, a single regional health information exchange that connects all providers, the ability to analyze all payer, all provider data in close to real time. And those kind of innovations take root much more easily in the single payer system than they have here.
Yes, Ron.
Dr. Apkon, you sort of hinted to the patient experience in Canada versus the U.S. Could you give us a little background on the journey that the patient goes through and how we compare?
Sure. The journey doesn't look too different. I think there's a few differences, and Massachusetts has done a very good job in terms of providing nearly universal coverage. So I'll leave that aside. Other states, not so much. But one difference is that virtually all Canadians have an identified family physician or primary care provider and have very ready access to primary care. The government has gone pretty far to ensure even in remote parts of the province, people have good access to primary care. I think that's probably one of the factors that leads to differential outcomes in patients with chronic disease. If you're a child born with cystic fibrosis in Canada, for example, you live 10 years longer than you do if you're born with cystic fibrosis in the US. And some of that, I think, is related to primary care. There are no barriers to access whatsoever. So you can walk into any physician, you can get any physician service, any hospital service, any hospital-based service like necessary imaging or laboratory services without any copay and without any barrier to access. There's been more recent investments in things like patient portals and things that make it easier to navigate the system, but truth is that there's still a fair amount of variation there compared to here. The quality of care is every bit as good as what I've experienced here. Operationally, at the front end of healthcare delivery, I really saw very little difference. People do talk about wait lists, and wait lists are a reality in Canada for some things. The truth is wait lists are a reality in this country as well, and we saw in many cases similar wait lists for things like childhood development, behavioral health services, things like that. If you need a service in Canada, the door to balloon times for patients with acute myocardial infarction are no different in Canada than they are here. If you have a new cancer diagnosis, there are standards that have to be met in terms of getting to see a surgeon, an oncologist, that are in the range of days or weeks, not months. But the truth is, if you need a hip replacement or a shoulder repair, something that is viewed as more elective, you may very well wait even as long as a year for that service. In this country, if you have the right insurance, I'm quite sure somebody will do that surgery tomorrow if you can get it scheduled and take the time off from work. If you don't have the right insurance, you might never be able to get it at all. So that's the way I would see some of the differences.
Yes.
Could I weigh in on
Please, Ms. Rothwell, yeah.
the patient experience here? And I just want to touch on the 4 points in the journey that we think consumers here in Massachusetts run into obstacles. So the first is around the shopping experience and determining the eligibility of which program they're eligible for and understanding all of that. The second is then understanding the actual coverage that they have and understanding high deductible plans and what their copays are. The third is then finding a provider and also dealing with care coordination issues. And then the fourth is around appeals and denials. And I would say that if we look at the information from our helpline, these are kind of the 4 big buckets where we think the consumer kind of bristles up against the complexity of the healthcare system, and these are where the questions often fall into one of these 4 buckets.
It's a great analytic framework for us to use. Thank you. Other questions? Yes. Rick.
So Amy, if you could wave your magic wand, those
today.
4 areas you just talked about, because we've been talking about getting consumers more engaged and educated, it feels like forever. And we used to say, well, there are no tools, and well, now there are tools, and the health plans have tools. She has great tools. Consumers don't really use them to any great extent. Are there things that we can do to help get consumers more engaged? And maybe, Cheryl, I don't know if you've done anything at Middlesex to do that too, so.
Yeah, I mean, I think, again, I'd go back to the point that we can give them tools, but when they're in the midst of making a decision, oftentimes they don't, as Meredith talked about, like have that moment in time to take a step back. The AG's report reminded us that they do follow the lead of what their primary care doctor is telling them. So I do think there's things that we can do with the system that will help. So for example, in terms of the shopping experience, I think the connector has done a lot to help standardize plans and think about the number. I do think there's probably always more room to be thinking about. This is probably the thing our helpline counselors would say is the #1 issue that they come up against, which is people have a great deal of difficulty understanding the choices that they have. I would say that the thinking about plan design and understanding that, understanding what they have to do and why it may be different if they're switching plans. Oftentimes transitions are really difficult times for people. So maybe a provider was a tier 2 provider in their old plan and now it's a tier 3 provider and they don't understand the difference. It's the same provider. We talked a little bit about the out-of-network and balanced billing. Care coordination. We hear 2 very distinct things on our helpline. So the first is that some folks are saying, we got an email the other day saying, like, I'm completely overwhelmed. I don't know how to manage all of these different incoming pieces of information. We have people who have specific needs. We had someone call the other day who had a brain injury and was saying, I just need someone who's going to help me process this because I can't understand it. Then the flip side of that is we hear the very complex patients often have so many care coordinators that they don't know actually how to manage their care coordinators. And that's actually something that happens. I would say that provider directories, there's a lot of work being done on that, but we need to keep moving forward. So I could give you more, but I'll stop there.
Okay, that's a good list. Yeah.
We have actually been working to educate our employees continually relating to health plan tools, the access for transparency. But I will tell you that it is a very weak take-up for our people. And part of that, I mean, there's a number of different reasons, but one of the things that we find is that obviously it's a busy life. They have a number of other things that they're looking at or that they're trying to raise their families. They're trying to take care of getting their children to soccer games and a bunch of other things. We also find that right now we have numerous generations in our workplace. And what they're looking for is multiple modalities of communication. And so for some, it's face-to-face, some it's on the phone, some it is give them an app, or some of them self-service. And so it's really challenging to get a large population to start to move on that. The last piece is that what we find is that part of the human condition is to really not go and look for tools unless they need them. And when they need them, they technically forget about them, and or they have difficulty managing them or maneuvering them, or maybe it's not exactly what the condition is that they're looking at or looking for. I think that the primary care provider, we find that many of our individuals are. They trust their primary care provider. They listen to them, and they believe that that they're telling them the right thing, no matter what. I will give you one example that we had recently. We have plans that we offer to our employees to try to bridge all of those generational gaps, and so we work with people who come on board as an orientation to try to help them determine what plan is right for you. Especially at your point in your life. And so we go through the process. The individual was a young man, went home and talked to his parents, and his parents said to him, "Oh, you need to pick the HMO Blue. You absolutely have to come out with the most expensive plan. You have to come back and you have to elect that plan." And so despite all the time and energy that we had spent with that particular individual trying to offer the options, literally going back to his parents was something that said that they had a much larger influence on him than we potentially could have, and he wasn't able to bring that back and communicate to them why other people thought that potentially he should look at that plan, this other plan. So there's a lot of inertia for people too. So I just think, and there's a lot of materials out there. Which one do you choose? Which one is accurate? And how do I know to trust those? So I would say that it is certainly a mountain for us to climb.
Thanks. First, I just want to thank Amy for bringing your perspective here. I think it's really important to get the consumer voice front and center, particularly of what we've been reviewing and seeing the numbers and how deeply disappointing they are. So I really appreciate you bringing that forward. I just have two quick thoughts or questions. One has to do with an earlier presentation that we ended with. I think it was Ashley from CHIA referenced the increasing retention of premiums amongst insurers and payers. And I'm wondering, as we're transitioning and moving to more APMs, I know that's steadied a little bit, but we've done a pretty good job transitioning there. Shouldn't we see a decrease in the need of retention, premium retention by payers? That's one. And then second, I guess, is we've also seen an increase, as we talked about earlier, the consumer spending in healthcare and cost sharing being pushed onto consumers. So I guess my other thought or question is, how much of the increase in administrative costs are driving the increase in consumers spending on their health insurance?
Can you clarify the second question? I'm not sure I understand it. I got the first one.
Yeah, that we're seeing an increase in administrative costs, or there's a big chunk of our healthcare dollars being spent on administrative costs, and we're seeing premiums increase for consumers. I'm wondering how much of the premium increase is directly related to the administrative cost of administering health insurance in the state of Massachusetts.
Okay, thank you. I appreciate that. I don't have the specific number, but in our case, I would say the number is fairly low. The big driver of premiums in our instance.
David, is your mic on?
Says it is.
A little closer to you.
The big driver for us remains medical costs. One. Two, some of the investments we made in, quote, retention actually have to do with, I was looking at 2018 information just to get current, and we made a fair amount of investments in improving our quality care program. Now that falls into retention, admin, but that's not something that we view as unnecessary admin. We believe that's worthwhile admin, and so we would want to invest in it. That said, and if you use the notion of how do we get more administratively simple or less complex, there are areas that we can invest in, and I'll bring up the authorization stuff first, that we can do a lot better job of taking down the administrative costs for that. And one way to do it is if you're in a relationship with a provider that's a full risk contract, you can delegate that authorization process to them, and you don't need to replicate it in your own system, because the incentives to get it right, both from a medical access, evidence of care, proper care, and cost are all aligned. So we've done that with partners. We eliminated all of the authorizations for them. We are in a full risk deal. They take a percentage of the premium, and that has worked out fine. When we looked at it, there was a slight uptick in a few areas. They have addressed that. One way for us to take out administrative complexity. It's easier for us to do with our own parent. I would say that in terms of using this as an example, authorizations are just a tool. They're not an end unto themselves. And so another thing we can do is automate this, make it much more so that it's an electronic transaction. But the gating factor being sometimes the health plan is waiting for information. Today, between faxes and phone calls and things like that, can take 3-4 days for all of this to get straightened out. If you were to automate that, the time goes way down, probably goes down by more than half, and the transaction cost probably goes down by more than half. So you're doing something up front to to kind of reduce that retention investment by doing things that you just don't need all those people anymore to do that kind of stuff. So those are the kinds of things that I think we have to do, and we have been doing. In our case, administrative costs aren't the big driver of our premium.
Can I follow up on this? So from 2016 to 2017, health plan administrative costs grew 19.2%. From 17 to 18, they grew another 16.9%. Should we expect to see continued double-digit growth in health plan administrative costs? At what point should we see some of these efficiencies come through? That's a question for you, David, and for you, Dr. Apkon. Are your administrative costs growing by 17, 20%? Start with you, Mr. Siegel.
When did you get so formal? Fair question. I don't have the data as to how much our admin costs have grown over this period of time. I don't know what the PMPM growth in the admin is based on the numbers that you just laid out. It's still likely to be very high. I think for us, some of the things that we're doing, we are trying to mitigate admin costs through the things I just talked about. We are trying to mitigate admin costs, and our colleagues at the Mass Association of Health Plans are trying to do this by creating standardizations around things like provider directories and things like that, that if you have multiple versions that we're asking each provider, do it this way for this health plan, that way for that health plan. If you can figure out a way to do it one way for all the health plans, then you save the administrative costs both on the provider side and on our side. How much dollars that translates into right now, I don't know, but I think the effort's there, the commitment's there, and the understanding that we have to do that is there.
So I can't tell you precisely what we're projecting for inflation in terms of our administrative costs. They're definitely going up. I think we have to take a hard look at the structure of the industry, though, and really look at, is there a motivation for the insurance industry to really manage the costs lower? With a requirement to hit a medical loss ratio of 80% or thereabouts, and anything that reduces the cost or the utilization, the payments out to providers is actually going back to people and not staying within the insurance company. If you look at some of the insurance companies, they're now actually diversifying their own business and growing into the helping manage the revenue cycle and the administrative complexity part of the industry. I think United is a company that, as one example, there are others that are now in the consulting business helping hospitals like ours manage the administrative complexity across all providers. I think where there's the most incentive is where there's integration between the provider and the payer. And so, looking at what's happening at Partners or what's happening in other parts of the country, look at Kaiser or Geisinger or places like that, there's much more motivation to manage the administrative complexity. We have a harder time engaging the payers in terms of managing the administrative complexity because in some ways it's what we rely on to manage the rules of the game, so to speak. And so there is less ability to do that with the providers that are not, or the payers that are not, where we're not integrated with them.
We're coming up on the schedule to close the session. I have David and Barbara in line for questions. Please go ahead.
So for at least the last 15 years or so, there have been various voluntary efforts to try and reduce administrative costs around setting standards for this and doing that and so on. And yet it hasn't happened. So I think I've concluded that we can't, that every time I hear we'll voluntarily work on this and therefore it'll happen, just to toss that out the window. And that what we need to do is to require things. And whatever is a good idea, the Commonwealth ought to require. Maybe the Secretary will disagree with me. And so I guess what I'm looking for...
Have you not read the governor's bill? It has single credentialing in it.
Yeah. So I guess what I'm looking for, and it doesn't have to be now, is what is it that we should require? Because I don't think waiting in the voluntary and the guideline adoption and then 5 years from there we're sort of partway there and stuff is working.
So I think there are two paths. One is through regulation requirements and looking at states that are moving towards, again, examples of either global budgeting or single fee schedules. But there's also the ability to use the state's purchasing power and the idea of a public option or something that could be a stalking horse for the rest of the industry in terms of minimal benefits packages, minimal benefit package, an approach to administrative complexity. I think it'll be interesting to watch what happens with Colorado, which has just introduced a bill for requiring insurance companies to offer essentially a similar public option, and to see how that drives things. If you look at the impact that Medicare has had in this country on just the shape of our healthcare system, the introduction of things like bundled payments, accountable care, that's really driven by a public option, if you will, for a large population that really has providers working in ways that will fit within the policy framework that Medicare has provided. I think there are opportunities for states to look at that at the same time that they look at the regulatory environment.
So I don't know which things you should require. I'll stay away from that one, but I will say this. If there are things that are going to be required, it's important to remember that healthcare is delivered across a broad spectrum of stakeholders. There are payers, there are providers, there's pharma, there's, on and on, and there's the consumer. Most of these problems can't get solved if an insurance company just does this, and it can't get solved if a provider just does that. And I'll give you a couple. The one that's most notable is provider directories. If we, the insurance industry, set it up so there's one portal in one place with one set of rules around here's what a provider directory is going to look like, it's only going to be as good as the timely information that we get from the provider community about who is actually in the panel, who is accepting patients, and who's not accepting patients. And that's not to say it's their fault, our fault, or anyone else's fault.
Mutual responsibility.
But all of these are shared business processes that if we're going to make it right for consumers and providers and everyone else, the requirements have to be across the board for everyone to play.
So I was just going to say, I think that this exact conversation is why you see so many consumers moving towards in the presidential discussions around Medicare for all or a single payer option, right? Because they don't know how else to figure out how to address all of this. And I agree that I think it has to be more than, bigger than any one industry. And I think from our standpoint, we want to make sure that the consumer is the one that ultimately benefits from this at the end. And I think we are up for being part of any discussion with any player at any time to talk about ways that we do this, as long as we ensure that at the end of the day, the consumers are the ones that are feeling at least equal savings, benefits, reducing stress. You know, there has to be some real skin in the game for everyone else to make sure that that is part of the equation.
Thanks. Barbara, last question.
Actually, I think David's question is an excellent place to pause.
All right, well, I will also punch David's question. I mean, I've been at this game a long, long time, and I've heard a lot of we're getting on it, and nothing's happened. 16.9% increase in administrative costs in this state last year. Something's got to change. I mean, to continue to do the stuff that sounds manifestly unwise, a 3-month wait and 16 phone calls to get a pre-auth done, or coding that just is no one understands. If we could have another panel with you, it would be like, okay, what's in the way? You know, and I can't figure it out, but I'm sort of with my colleagues here that it's time to stop the waste. But that said, thank you. You gave us a lot of great ideas, and it was wonderful to have you here. Thank you very much.
So I just want to add a corollary to what Don said, because it's not only the administrative complexity and the savings in the PMPM, it's not having any benefit to the consumers who are paying more out of pocket. It's more complex, and their premiums are going up, and we're seeing behaviors that employers are needing to engage in order to try to keep their costs down. So it really is this unfair at this moment.
Mm-hmm.
Marty?
I believe it's lunchtime.
Boy,
We will, thank the panel, and we will reconvene at 1:30.